the board has decided to facilitate such an event to highlight the work outputs of the hospital over the past year, its many challenges, and to present its plans and programs of the ensuing financial year. So that sets the tone for why we're here this evening. And I welcome you, those of you who are here, members of the board, the medical profession, and of course the general public. Our agenda for this evening follows this order, so that you can be abreast as to the format and so what we are offering. Now, our feature address will be offered by the Executive Chair. Followed by that, we'll have a presentation by Mr. Adrian Hurley. He's Director of Financial Services here at the QEH. And that will be followed by another presentation by Dr. Clyde Cave, Director of Medical Services acting here at the QEH. And then you will have a chance to offer your questions, and of course they will be answered, and then the wrap-up. The feature address is being presented by, as I indicated earlier, the Executive Chairman of the Queen Elizabeth Hospital. And in this role, she chairs the Board of Directors and manages the operation of QEH, Harrison Point, and associated public-private NGO services level agreements. The Executive Chair brings a background and proven excellence and experience in organizational transformation with an emerging specialization in crisis and transition leadership. And she has led in the transformation of the CARICOM-based Pan-Caribbean Partnership on HIV and AIDS, the IPPF affiliate Barbados Family Planning Association, and has been engaged by USAID implementation partners as Chief of Party on regional projects in need of strengthened leadership. She has also led the development of the World Bank-funded Barbados National Strategic Plan for HIV, Investing for Results 2014 to 2019, and repositioned the national program to be in alignment with best practice and local needs. Her leadership has been mainly in the public health and health system strengthening arena and are undergirded by transcultural experiences such as the Research Fellow in Cancer and Public Health for the London School of Hygiene and Tropical Medicine, and in palliative care at the University College London. You would note, ladies and gentlemen, that with such an interesting profile, that our feature speaker is aptly capable of presenting to you the plans for QEH in her capacity as Executive Chairman. So I take great pleasure now in inviting her to offer her address.
Thank you very much. Then Maria are going to help me with the slides. Thank you. Thank you very much, Antoine Williams, and thank you, all of you here in the auditorium of the Queen Elizabeth Hospital, my fellow member of the head table, Dr. Clive Cave, as well as those of you who are joining us through the Barbados Government Information System portal on YouTube. It is indeed a pleasure to address you this afternoon. This is our 6th annual public accountability meeting. In the year 2019, the government of Barbados would have passed the Public Finance Management Act, and that act demands of state-owned enterprises at Section 118 that each state-owned enterprise, and in particular commercial state-owned enterprises such as Queen Elizabeth Hospital, conduct a public accountability meeting. This is part of the discipline that the government is insisting that state-owned enterprises be held to, and we are very much have been ahead of the curve in this regard as an institution, in that this is our 6th such meeting, and we are very pleased to address the public in this regard. I share the leadership role at the hospital with an esteemed group of persons on the board of directors as well as executive directors. Together, we are bound by the Act and its requirements. I'd just like to introduce you to members of the board, some of which are present this evening. Dr. Abdul Muhammad, Deputy Chairman, Mr. Andrew Niles, Chair, Finance and General Purposes Committee, Mr. Nigel Whitehall, Chair of the HR and Tenders Committee, Dr. Jackie King, Chair of the Patient Care Committee, Ms. Sharon Christie, Chair of the Audit Committee, Mr. Joseph Lafloof, Chair of the Infrastructure Committee, Dr. Annalie Babb, Professor the Honorable Udine Barato, Mr. Dennis DePisa, Dr. Kenneth George, our Chief Medical Officer, Ms. Janet Phillips, our Permanent Secretary, Ministry of Health and Wellness, and Shirley Ford, our Board Secretaries. Also joining us this evening are our 5 executive leaders across the hospital: Dr. Clive Cave, Medical Services Director, Ms. Louise Bob, Support Services Director, Ms. Susan Reeves, Human Resources Director, Mr. Henderson Pinder, Nursing Director, Ms. Paula Agbowu, Engineering Services Director, and Mr. Adrian Hurley, our Financial Services Director. Next, what we will be doing, sharing with you this afternoon, is taking you on a journey that started essentially in 2018. We were convened as a board in June 2018, and what we are going to share with you this evening is the nature of our health system, key challenges that we faced when we started in 2017, and exactly what we did about those challenges, highlighting our key achievements, and then our performance dashboard. We'll share with you, as required by the Act, how we spent the financial resources that were allocated to us, focusing on financials years 2018 and 19. And we're also going to go and showcase for you what new strategies are being pursued in our strategic plan and our operational budget and program budget for the upcoming 2 years. Then I'll hand over to Dr. Cave to really drill down on some clinical issues that are of public interest. In order to understand the hospital, it's important to understand the health system. And I had the opportunity many years ago, I'm aging myself, in 1997, 98, to be taught by a professor of health policy, Jill Walt, at the London School of Hygiene and Tropical Medicine. I did not know then that key teachings that she would have imparted would really come to be so central in what we're faced with. And she said, essentially, that the behavior of various actors in a hospital is tied to design of the health system, power relationships that exist in that system, and the varied influence of stakeholders over the process of policy making. So, in order to understand the hospital and what is happening here, I'm just going to begin briefly by helping you to understand the health system in which the QEH operates. All services are free at the point of delivery. There are no user fees charged in Barbados. Costs are borne by taxpayers and revenue generated from private rooms and services and charitable donations. The care levels and pace is managed by waiting lists, and we do rationing and prioritization of services based on the assessments of physicians. Our surgical waiting lists are managed by individual surgeons, and the way that we remunerate our key consultants is through an established public and private mix of payment. Our consultants work here, and they work as well in the private sector. We conduct within the Queen Elizabeth Hospital a dual system of public care and private care, operating in the private wards and wings of the Queen Elizabeth Hospital. And we also process services and care that is not available here at the Queen Elizabeth Hospital, but may be available in the private sector or available abroad, we are able to access for Barbadians through the medical aid scheme administered by the Ministry of Health. We also, many people are not aware, provide a significant amount of services to the polyclinic system. We do all of the labs, we do a significant number of dressings, and we provide services free to the primary care system that is operating here in Barbados. We have seen the direct impact of the commencement of the 24-hour system in the Sir Winston Scott Polyclinic, and we expect further reductions to occur with training and building out of the infrastructure at the Sir Winston Scott and other facilities. Although we are board of directors, we are still tied to public financing as recipients of public funds, and all of our positions have to be established within the context of the Ministry of the Civil Service. So there's a close relationship between the Queen Elizabeth Hospital and norms and practices that exist within the wider public service. When we came to the Queen Elizabeth Hospital as a board in July 2018, we met a number of strengths, weaknesses, opportunities, and threats. I'll quickly speak to these. We had very well qualified staff in many areas. We had emerging centers of excellence that Dr. Cave will speak to. We were maintaining, as our data will show later on, key service levels despite financial constraints that the country and government were experiencing. We were already looking to strengthen our nursing capacity and had hired nurses from the Philippines, Nigeria, and the wider Caribbean region. We had developed a cardiac suite and were building out our cardiology services. And we had partnerships with the government of Republic of China, Sick Kids, and Transplant Links, as well as the World Pediatrics projects helping us to deliver care. But we also met significant and deep-seated weaknesses. We had insufficient numbers of doctors, nurses, and staff in critical areas. We had long waiting times and poor conditions, particularly in the accident and emergency room. People were waiting for up to 8 months, in some instances for things like colonoscopies. We had no bed management programs operating at the hospital, and the spectra that continues of elderly for care, young for care, and social cases in residence and living at the hospital. We also had under-financing and weak cash flow. The management team will tell you on a week-on-week basis they were spending time looking to see what resources they had and what available to spend, and therefore we had lost a tremendous amount of supplier confidence, and we were experiencing significant stockouts. A lot of our equipment was obsolete and end of life. The government had been unable over a prolonged period to make significant and substantive investments in equipment. We had outstanding audits since 2011. We had patient satisfaction that was a mixed bag. Some people were having good experiences, but increasingly with the growth of social media, those who were not having good experiences were sharing and broadcasting what was happening in their experiences here at the hospital. And we had very weak systems for discipline and accountability within the hospital. But however, 2018 was a seminal year because it presented significant opportunities. The government had entered into the BERT program, which indicated that it would restructure local debt. And we then were required, as part of that arrangement, to ensure that we were paying all of our suppliers within 30 days of the presentation of an invoice, and that was expected to immediately redound to the benefit that people who were selling us services, giving us supplies, would once again be getting the assurance that they would receive payments. We had very high interest in charitable giving to the Queen Elizabeth Hospital. We had the government had established a new ministry, the Ministry of Science and Technology and innovation, sorry. And so there was a strategic interest in technology and using technology to drive development across the public sector. And we had expanding training of nurses at the University of the West Indies, and an arrangement being developed with Ross's sister university, Chamberlain. But we still had threats, and threats that have continued with us, of an organizational culture here at the Queen Elizabeth Hospital that is very relational, lacks accountability, and there was a real perception then of management disinterest. We also had a lack of a performance culture, although we were beginning to develop key performance indicators. The management team said that this kind of use of indicators was not deeply embedded and not used widely throughout the organization. We had a low throughput of local nurses. Our local nursing shortage was severe at that time, and we had burnout and low morale and deep-seated cynicism within the staff complement of the hospital. And we were also aware of industrial relations turbulence, the specter of people walking out and going under the tree, as it is colloquially referred to in the hospital, was very much present. And as with the society, as within the Queen Elizabeth Hospital, we had increased societal violence, threats to staff and patients in wards of the hospitals, with the increase in gun violence, fears that people were chasing people into the hospital or would come to finish the job that was started within the hospital. We had theft of the hospital property and vandalism of premises or public bathrooms. Maybe perhaps once a quarter we have to go and repair. We're not sure what the interest is in our public bathrooms, but there seems to be deep interest in vandalizing them and stealing soap, and so the hospital really was facing some challenges. Next slide. But we recognize as a board and as a management team that the old adage that Rome was not built in a day really held through. And although Rome took over 100 years to build to the state that you see it there, we recognize, because of the expectation that the public had of us, the fact that the government had introduced a health levy, which was an additional tax on the public of Barbados, that we had to run not one of the traditional Roman marathons, but a quick 100-yard dash in order to quickly get on top of the situation that we found ourselves in. And we want to share with you what we did and some of the achievements we were able to achieve within the first 2 years. We knew we were facing concerns about delays in the performance of surgeries. All Barbadians knows that this is a problem that the hospital faced. So many of you have situations where you've been awaiting surgeries, or you're scheduled for surgery and your surgery is delayed and you have to go back down. So we did an investigation. We were told that delays in surgeries are due to a lack of anesthesiologists, and that is shown in the reports produced to the patient care committee, and shortages of nurses to be able to expand the hours, and a breakdown of equipment and or air conditioning systems were faulty at that period. So what did we do? We purchased autoclaves, 4 autoclaves, so that we could have a faster turnaround of sterilization of equipment. In the group of nurses, we would have hired 9 operating theater nurses from Ghana. We'd have purchased a lot of equipment, just highlighting 2 here, microscope for neurosurgery, microscope for ENT, so we can speed up the waiting list for surgery in those areas. We hired an additional 2 anesthesiologists, and we replaced the end-of-life chillers that were in the air conditioning system, so we would no longer have the spectra of surgeries not being able to be performed because our air conditioning systems were working. So we then said we had long waiting times and severe congestion in the accident emergency room. That was considered mission critical, and we launched a capital works project, which is underway to build and expand the accident and emergency room. We also created a short stay unit at Ward C3 so to overflow patients in the A&E who needed to be warded or houses temporarily before a decision was taken to be admitted. We created the short stay unit. We also created a new bed management unit, recognizing that most of the issues facing the A&E have to do with congestions within the hospital, some inefficiencies that exist across departments, and therefore patients are staying in beds longer than they need to. So we had to have a dedicated team that was essentially focused specifically on the movement of patients in and out of beds and managing cases, finding out if there were any bottlenecks with patients who were in beds for prolonged periods awaiting diagnostic or other services. We also repaired the X-ray and other equipment in the accident and emergency room to be able to speed up. We also had a poor response to patients' complaints and concerns, and we would have launch QEH TV. We are establishing a quality and patient experience department within the hospital. We have trained personnel now to be in a position to do that, and we've been upgrading our ward, particularly with the assistance of the private sector. We also, as we said earlier, we're tackling the area of poor financial management and weak cash flow. We recognize this as a challenge, and we would have now recognized the need to expand the professional staff dedicated to these issues within the hospital. So we would have hired 2 ACCA qualified chartered accountants and a procurement specialist out of the private sector. We also had from the BERT program an investment of $19.8 million in clearing our debt. This is important. Cannot emphasize how important. Part of that IMF program that people talk about directly benefited the Queen Elizabeth Hospital in that the government would have utilized the resources that it obtained to basically clear the hospital from a massive amount of debt that it was carrying to banks, to overseas and local funders, so that we would be able to start restocking the hospital systematically and start the flow of supplies and end the specter of continuous stockouts that were happening because we were unable to pay our suppliers. We also activated our audit department, internal audit department, and audit committee. We have an audit committee that meets on a monthly basis and set about the task of bringing all of our audits up to date. We had audits with PricewaterhouseCoopers from 2012 through to 2016, and with Crowe Barbados from 2017 through to 2019. And I'm pleased to say that we are now just awaiting the management letters, and we will be submitting all of these outstanding audits to the Auditor General before the end of this month. We also recognize the importance of digitization and automation, and we would have automated our inventory management system so we can have a better sense of our power levels, understand what supplement suppliers are getting out of stock, and more importantly, have people being able to requisition supplies directly from the ward. We also had a storage system that had not been expanded, perhaps since the hospital was created, and our storage areas of the hospital were just completely congested. And so we would have opened a warehouse in Green Hill to be able to house additional stock. That, within the space of about, 8 months, Adrian, became filled. and we're now looking for expanded storage capacity and have identified warehousing in the Wilde area. We were able, as a result of expanding our stock, to reduce our net stockout position by 50%, and we made a very strategic decision that we would tender just about everything that we had as widely as possible to benefit from the efficiencies that come from going to market. And also, very important in our tendering process, we were very, very consistent with and committed to the government's policy of ensuring that small and micro enterprise businesses were able to get a piece of the pie, so to speak. So in our tendering processes, we very purposefully set aside 40% of our tenders for small businesses, businesses that are women-owned, businesses that are owned by people with disability, young people, to ensure that they would be able to tender and get access to the opportunities that existed here. And not only did we just put the tenders out there, we did training and capacity building with these groups in association with the Ministry of Small Business and Commerce and the Barbados Youth Business Trust to be able to empower and equip these small businesses to be able to apply for formal tenders. So it's been a developmental model, but still ensuring that we got the best market prices as far as possible for our services. To address our severe nursing shortages, we would have been working with the Barbados Community College to improve the throughput of Barbadian nurses, and I understand that we've gotten significant improvements in that regard. So we have hired graduate nurses that weren't quite complete, and we're now pleased to say that nurses are beginning to flow from the Barbados Community College, and we have retained some vacancies here at the hospital to be filled by Barbadian nurses as they graduate. We also hired 49 Ghanaian nurses on 2-year contracts, 4 nurses from the Philippines, and 100 Cuban nurses. So we've really, really focused heavily on building out our nursing shortage, since that was said to be a key aspect of our delays. We also had, in the next slide, we also have long bed stay days. You'll see shortly in our map that our bed stay days, people are in the hospital much longer than they need to be. But they're here in very many instances because of inefficiencies that exist within the hospital. Patients are in beds waiting to get x-rays. They may be waiting for orderly transport before they are discharged, waiting to leave the hospital and get external tests from our partners in the private sector. So what are some of the things that we did? We would have purchased a mobile x-ray that's able to go to the bedside and do x-rays there. Our bed management unit started case management, so they were able to pick out some of those outliers, patients that were simply in the beds too long, and then intervened on a case-by-case basis. And we introduced communications equipment for our orderly pool to be able to improve our management of this workforce that tended to be dispersed across the hospital. We had an extensive amount of obsolete and unreliable equipment across the hospital. Those of you who work here can tell you it is really a source of frustration for the engineering team and then for the users themselves. And I'll report to you in a second, we would have had an injection of over $18 million in capital equipment to the Queen Elizabeth Hospital to be able to improve our equipment. That is the single largest injection of capital equipment that has occurred for the Queen Elizabeth Hospital, and I think the government is to be commended for recognizing that it had to prioritize investing in equipment in order to provide and meet the needs of the Barbadian public. We also had very deficient discharge planning processes and procedures, and therefore recurrent readmissions so there were patients that were referred to as frequent flyers, meaning they were discharged and then with a few weeks it would reoccur. And we also, it's an open secret that Barbados has not been doing well in terms of our outcomes in cardiovascular care. And as a result, you would have heard our Prime Minister speak in Parliament to the need to launch a national cardiology project that was specifically targeting the systemic issues that were resulting in these poor outcomes for Barbados. We also have undersubscribed kidney transplantation services and oversubscribed kidney dialysis services, and these are areas that we've recognized that we needed to work to, and Dr. Cave will speak to them some more. What we have done, recognizing that we had these challenges, is not throw our hands up, started our community nursing project where we're going to put 40 community workers who are hired to work directly in the community, following 500 patients who have been identified between our diabetes, cardiology, and hypertension cardiology clinics. We're going to follow these patients into the community and essentially ensure that they're able to get the necessary follow-up care. This leadership for this is going to be done by Dr. Russell Broom-Webster and Wendy Lord and the team in the social work department. We're really looking forward to how this is going to impact the continuous flow of repeat visitors and help families to be better able to cope with caring for elderly persons or persons with chronic illnesses who have returned and been discharged from the hospital. Mr. Tony Harris, many people know him as our DMS, has been deployed to the Ministry of Health to support the team there in really building out the National Cardiology Program. And we have created a kidney transplant unit on the A floor, and we're in the process of working with government to implement organ transplantation legislation so that we can expand the number of persons who are able to donate kidneys and be able to access kidneys from persons who have passed away and be able to provide a much better quality of life for persons who are now on dialysis and need to be able to have a kidney, a repaired kidney or a new kidney in this instance, and function much better than having to come 2 or 3 times a week to the dialysis clinic. So this legislation and this unit really will take us far in reducing some of those challenges. I was at pains to talk to you about, very honestly and frankly, about our challenges, because in order for us to really understand the issues, we have to understand what we're facing and the root causes of it. It's important for me also in a setting of this nature just to share with you some data. I'm pleased to say that we have our first Queen Elizabeth Hospital data digest. It is being circulated. It is going to be made available on our website, or we're going to share it with our NGO partners, or you can collect it. We think it's important that people get an appreciation of our numbers and the volume and scale of services that we're doing. So we produced a small user-friendly document. Let me just grab one. It's just a leaflet that opens out where you can really get a sense, and I've just pulled just a couple of slides that may be of interest for you so you can get an idea of the kind of data, how we manage and how we make decisions at the hospital. So for instance, we're now in discussions with the Barbados Fire Service as to how we can strengthen our relationship and decentralize our ambulance service. It's already happening at the Arch Hall Fire Station, and we're looking very carefully at the possibility of if we can co-locate our headquarters of our emergency ambulance service with the new headquarters of the fire service. But this relationship between the fire service and the Queen Elizabeth Hospital Emergency Ambulance Service will take us a long way. The figures there show you that the closer you can locate ambulances to population density points, the quicker you're able to get ambulance deployed. And you can see the short length of time between where we have 12 minutes in St. James, where close to Arch Hall. So the closer we're able to locate ambulances to population, the better we're able to do. And it just gives you an idea of or numbers of calls that we would have done in the year 2019. Next slide. Our missions. Lynn Marie. Next slide. Admissions. This is just a quick snapshot of the numbers of admissions we've had. And I want you to pay particular attention to what is happening in the Department of Medicine. You can see we have pretty long lengths of stays. This puts you back to what I talked about, our systemic challenges in the Department of Medicine. And these are length of stays, 8.9 in 2017, and going on to in 2019, 10.6. Just gives you a sense of that we really have this department, patients staying here longer than perhaps other departments. The other area that we are having long length of stays are in the Department of Surgery. We're pretty inefficient in this area. We have people coming in and waiting in beds to be able to get surgeries. And in many instances, if we can get a minor case unit going, we'll be able to start doing day case, ambulatory case services if we set up a pre-anesthetic clinic here within the hospital. These are all things we're planning to do. We're able then to have patients better evaluated before they go to surgery, so that when the appointed hour comes for their surgical procedure, we don't then have a delay because the patient's blood pressure or other indicators off, so then the patient surgery has to be delayed. So we think we can do better in terms of the efficiency, particularly in these two areas, and it is something you'll see us talk about more consistently. The utilization of our outpatient clinics. This is important. We're giving you our figures. All of these are in our data digest, but you can see our largest clinics really are in our ophthalmology clinic. This has to do with a lot of diseases associated with diabetes and the chronic disease, non-communicable disease epidemic. And essentially, you've been seeing the growth in that ophthalmology clinic between 2017 and 2019, and the continued growth in many in the medicine clinic as well. So we know the areas that we have to strategically focus on, and our data speaks to us very loudly on where we need to put our strategic emphasis. As an institution, we determined that it is important to really use data to guide decision making. Just a few, because we know elderly for care is a particular challenge, showing you again the growth of elderly for care between 2017, 2018, and 2019, growing from 151 to 163, and by the time we reach 2019, up to 200. And as you're quite aware, we are still struggling with this issue. The issue of young for care, this is a group that is often overlooked. These are people that don't fall into the elderly category, but they're younger, but they may be homeless, they may be indigent, or they may be social cases. And those persons, you can see the number growing between 2018 from 5 to by the time we reach 2019, 39. When we're showing you this, these are people that eventually came to live in the hospital over that period of time. So when people are experiencing challenges in our accident and emergency room, it is like a bottleneck. It's the equivalent to what we call the old Pepsi bottle, that people are coming in, but essentially the hospital itself, we're not able to get people out of the beds quickly enough and safely enough to be able to, because we have some residents who are living with us. So multi-sectoral partners, ourselves, Ministry of Health, Ministry of People Empowerment, non-governmental organizations have to work together to be able to solve this problem. Just giving you some numbers for from our snapshot. We have 85% in our, over the years between 2017, 18, and 19. We've been pretty consistent with our mix of public surgeries versus private surgeries, running in the vicinity of about 84, 85% public surgeries and 16% private surgeries. The Department of Nephrology, this is a fancy name, or the correct clinical name for our dialysis unit. This is a really important slide because it shows you the challenge we've been having with maintaining this service. You'll see numbers in 2017, and you'll see the growth of the number of dialysis patients, 71 to 94, 88. But if you look now at our numbers of patients who are in or within being serviced by our AK unit here within the hospital, you see consistently high numbers over the period of time. And if you look, we made a strategic decision as a board in 2018. It was one of the early decisions that we would have taken, that we recognize that this number of patients who need dialysis care, because it was ballooning and being way beyond the capacity of the team in the artificial kidney unit we increase our outsourcing of kidney dialysis services to a partnership with the Maria Holder Memorial Trust Diabetes Foundation, and we now are outsourcing an additional number of diabetes chairs at that facility in association with a private partner, SILS. So you'll see us grow from 68 outsourced patients to 116 by the end of 2019. And this area is an area of significant and substantive costs to the hospital. It's one of our most expensive units. But I often say you cannot put a price tag on care. You cannot put a price tag on quality of life. So we recognize that as long as we have the chronic disease epidemic raging, the hospital is going to be called to meet these, to finance this area as a service area, and hence why we're pushing so hard to grow our kidney dialysis program so that patients who qualify, who are healthy, can come off dialysis and be able to have a better quality of life. Next slide. Our clinical risk management unit, we thought we would share with you. We do track our complaints, and we have a department that is just focused on receiving complaints that are received online. You can send complaints through feedback, or if we get them on the internet, or people families contact us. But what I want to share with you that is interesting about these complaints numbers are what the public have said once we've investigated and gotten to the root cause of the issues. We've recognized that a significant of complaints are around issues of communication between doctors and nurses in particular, and with the patients, and staff attitude and behavior. A lot of complaints about the behavior of our staff, and it is something that we're facing squarely as an institution and addressing it. So our data tells us where we have to emphasize, and it is where we are beginning to focus on. And we also have a significant amount of complaints as people become more aware, as people want to be engaged more actively in their care, we see complaints growing and questions being raised around the issue of clinical treatment. Our pharmacy department is a department small in size but large in scope, and it would be remiss of me to stop presenting numbers if I didn't share with you the sheer numbers of prescriptions that are passing through that pharmacy department. Naomi and the team, Trudy and the team are really doing a significant amount of work, and you see the numbers of prescriptions that are being dispensed here at the Queen Elizabeth Hospital. Our pharmacy does not just do prescriptions for inpatients, it does prescriptions for outpatient services as well. So our pharmacists are juggling the needs of our hospital patients as well as those who are coming from outside of the department. I'm about to show, there's one of the key rules. I'm going to talk about equipment purchase, and this is important. And next slide. When you're being taught PowerPoint, they say to you, never do slides that are too busy. But I'm actually defying all of the rules and guidance on the presentation of PowerPoints, because I think it is important to share with you 3 slides to give you the sheer magnitude of the kind of investment that has been made in equipment and what some of the key pieces of equipment actually cost and what they're like, how they're going to be directly improving patient care. So just giving you a sense of what we've been purchasing beds, ECG machines, surgical instruments. Part of the delays in surgeries is that we have a small set of instruments. They then have to, once the procedure is done, they have to be sent to be sterilized and brought back up into the surgery. Of course, that is inefficient. So we're expanding the number of surgical instruments so we can be doing a lot more surgeries at the facility. We also, the cardiac C-arm, critical pieces of equipment we have replaced. The neurosurgery microscope, Dr. Gill was struggling for a significant time doing surgeries and having a very, very, very difficult time seeing through the instrumentation. And I remember when he presented this to me and he said it was going to cost 1.3 thousand. I just could not imagine that a single piece microscope could cost over $1.3 million. So I'm just giving you, the public of Barbados, really a clear sense of what is involved in getting that $18 million in investment, the kinds of equipment we've had to buy, x-ray machine, because the hospital was functioning for so many years. You'd go and you're sitting, you can't understand why you're waiting so long. You're waiting long because the engineering departments, a term I learned when I came to the hospital was the term Collifox. I had never heard that term before I arrived at QH, but essentially our engineers were collifoxing, like pulling from one piece and trying to make something out of the available equipment, and they had been struggling with that for many years. So just giving you a sense of the level of upgrades that we would have had to do. A medical air plant, trolleys, fixing the stairs, replacing our elevators. We have elevators where we transmit patients, garbage, service elevators, everything happening in the same elevators. When we're able to repair our elevators, we can set aside a service elevator. So really modernizing our water tank capacity. We've expanded significantly, and we've moved from, how many days, Paula? From days. From 2.5 days to, from 14 hours to 2.5 days. So should we have an emergency, the hospital can work for 2.5 days awaiting the arrival of water, because we were in a situation where we only literally had 14 hours when we started this journey. So water tanks, cardiac monitors, Lastly, fetal monitors. I mean, a significant investment in equipment for the hospital to be able to all parts, not just clinical areas, our kitchen, our IT department, a real substantive investment. We've purchased an additional ambulance, just giving you a sense of what was required to really address the substantial issues of plant and equipment that we were facing here at the Queen Elizabeth Hospital. Altogether, the government would have put $18.8 million into this. You can skip down, Lynn Marie. Continue. Thanks. So having recognized the importance in investing in plant and equipment, we also recognize that you have to invest in staff. Going back to the very beginning, where we recognized that we were having staff burnout, a lot of cynicism, people really unhappy with the space and conditions of work that they were confronting. What we would have done is really invest heavily. As a board, we subscribe to the Richard Branson adage that says that if you invest in your staff will look after your clients. And that was something he had put into management lexicon, and we took it to heart, and we really invested heavily. We'd have refurbished the nurses' lounge that benefits about 615 nurses of all categories. We would have changed and upgraded the general workers' changing room. The fitter welders workshop was in a state of disrepair, maybe for about, I'm not exaggerating when I say about 30 years, because I like to say I had seen it many years when I think Brian King was still here as the chief radiographer. That's how far back. So we're talking about over 20 years, and the condition of the room that our fitter welders that do all of the mechanical work have remained unchanged. And so we would have repaired that area and provided those workers with a changing room. Our biomedical workshop was an occupational hazard when we went in there during our first, I see Jackie shaking her head, as our first trip as a board. It was extremely congested. It was just, the men really there was no place for the staff to work. We would have expanded the biomedical workshop, and actually, as part of our expansion of our storage facilities in Wilde, we're actually including space to bring the biomedical team to an even more expanded area that they can work on the repair. We have over 7,000 pieces of equipment that we have to do preventative maintenance on. And so we have lab remediation. This project started in about 2016. We have been working to deal with issues of ventilation, of mold and mildew. The lab is situated between heat pipes and cool air conditioning systems, and it's a perfect storm for mold and fungus to grow, and it's been a struggle for this department, and we have really been doing lab remediation works, quickening our pace in that regard, benefiting 51 workers. Our pharmacy oncology team that caters to cancer patients had been working under unsafe conditions, and we lobbied with the Ministry of Health, and we would have gotten temporary space at the Best Los Santos lab for them to be able to do the mixing of chemotherapy drugs safely. Unfortunately, and I know Ministry, the Best Los Santos lab will tell you that 6 weeks bar has gone into about 2 years, so we're really looking as quickly as we can to really have our own internal capacity to be mixing those chemotherapy drugs here at the Queen Elizabeth Hospital. But staff safety comes first, and until we're able to do that, it is part of our capital acts. For the next financial year, we will continue to have them working with our partners at Best Los Santos. Our painters and carpenters are below the incinerator, which all of Barbados knows by now is broken. It is 10 to 12 years past end of life. And it was really struggling on and spewing out all kinds of soot. So we have to really move our carpenter and painter's workshop. And we would have refurbished our kitchen and really looked at cooling that area. And our orderlies are working in some really substandard condition. When it rained, those of you that know the bottom of the hospital, water literally runs through, and our orderlies were working and having to contend with walking through water. So we recognize that as a board, we could not ask our staff to go that extra mile unless we invested heavily in improving the conditions of work for them. And this is something we focused on, and we received good appreciation from the staff in this regard. We still have a long way to go because, as you know, it is an aged plant. Next slide. We are now in a position to give all of our staff hazard pay. The recent supplementary that was given gave us an additional injection of $35 million as part of our COVID response. So we're looking to pay all of our staff who have been on the front line working with COVID positive patients and additional supplementary payments. And we have been doing upgrades of information systems, security systems, and we have been recruiting as far as we can. And we have looking to bring world-class physicians here to the Queen Elizabeth Hospital. We've attracted a pediatric cardiologist out of the UK of Barbadian descent, but working in the UK. Cardiologists are recruited, interventional cardiologists recruited from Venezuela, Dr. Lugo. And we have Dr. Chantal Brown-Farmer, a pediatric hematologist, who has also joined us. And we also have been doing succession planning, or Professor Corbin is at retirement and really has worked hard and assiduously to obtain a fellowship for Dr. Jacinta Simonetto. She will be going off. COVID has slowed that down to the UK, so we have another Barbadian neurologist who will be looking to take up the mantle from Professor Corbin. We also have sought to really reduce industrial unrest. We work very closely with our trade unions and shop stewards, and you're going to see us talk a little more about peopling and the role of our staff clinic and wellness. Next. In terms of our other achievements, as you know, we're in the COVID pandemic, and it is important for us. We cannot take this for granted because so many other hospitals have been affected. To date, we're really pleased to say that no staff or patients here at the Queen Elizabeth Hospital have contracted COVID. We launched a new innovation through a medication delivery program with a private sector partner, Hopscotch. We're soon going to be involving that to a partnership with the Postal Service, having deliveries made, and that can be arranged through the Postal Service. We've maintained high levels of personal protective equipment. Queen Elizabeth Hospital, unlike many hospitals around the world, was able to ensure that we had critical PPE, and we would have upgraded and more transformed Black Mangala and work with the Barbados Defence Force to really look at having some new facilities in place as our epidemic. But the piece de resistance, the apple of our eye, remains Harrison's Point, which we're very proud of and has been delivering services up to now to 333 COVID positive patients. I'm not going to spend time on this, but just to let you know that part of how we measure what we do as a management team is that we have a service performance dashboard. So we're able to know what our key performance indicators are. what target we're seeking to meet, and whether we're trending in the right direction or trending not in the right direction. So you already see when we talked about earlier, we're trending in the wrong direction, which is upward in terms of our length of stay. And we have had an increasing number of medical aid referrals, and our outpatient clinics are increasing and expanding. All of this you are already aware of. I'm going to focus on the next dashboard for accident and emergency room. And it's important for a look at where we are. We're trending well in terms of or life-threatening areas that is going in the direction. But you'll notice our category 3, which are our clients that are non-urgent but require treatment at the hospital. These are the people who tend to have the longest waiting time, and we're tracking that this is an area that we have to do better in terms of our performance. We already talked about, we are tracking complaints, adverse incidents that occur, all adverse incidents that occur that are clinical in nature. We have that investigated, and we give a reply and a response, and we're really pleased that we are doing well in terms of the length of time it takes us to get back to either partners within or outside of the hospital in terms of the response to the complaint or having a reply done within 60 working days. Next slide. We are pleased to have a hospital where 100% of our physicians are credentials. But you can see an area that I wanted to share with you. We have a challenge at the hospital with absenteeism and sick time. It is not trending in the correct direction. So this is something you'll see us talk about very shortly. And what are we going to do where we recognize that there are areas that we have challenges? There's a direct relationship between what the data tells us are our challenges and the responses that we are making. I'm going to hand over now to our finance manager, Adrian Hurley, who's going to talk about our financial performance over the financial years 2017 to 2020, and then I'll come back to the podium. Adrian?
Good evening. The hospital, as the island's only primary health care system, has been funded by the government over the years. The years under review here, I'm going to start with the revenue. In financial year 2017-2018, the government would have funded the hospital with $172 million. The hospital itself would have generated about $12 billion on its own through private practice and private surgeries and donations. I want to get back to the private practice and donations part of that, because that is going to be critical to the hospital going forward as we look at our sustainability and our funding and revenue generation. During the financial year 2018-2019, the government changed the hospital's funding model slightly and reduced where from 2017-2018, where the budget was solely funded by government subvention. In 2018-2019, during that financial year, the government changed the finance model for the hospital, where it introduced the health levy, which was levied on workers through the NIS system. And therefore, that would have changed the quantum during the that would have begun in financial year 2018-2019, and would have come in full effect in 2019-2020. In 2018-2019, the health levy would have generated $14.9 million, and in 2019-2020, $66 million. With the advent of COVID, however, going forward, we expect that number to fall, and we predict that in this financial year, that figure should be around $56 million. I want to change to expenditure. What I want you to notice is that the hospital spends essentially 60%, roughly around 60% of its budget on salaries and wages, on human resources. So essentially that leaves the hospital with about 40 cents in the dollar to run the rest of its operations. And in the financial year 2018-2019, the government through the BERT program would have liquidated debt and overdraft, which would accumulated $2.2 million of interest in that financial year, which is $2.2 million which was diverted from healthcare and patient care. So the elimination of that debt, as you can see, would have reduced our finance cost compared with in 2019-2020 from $2.2 million to $600,000, pardon me. Now, that $600,000 is mainly exchange levy, since the hospital purchased a huge amount of its material and services from overseas. Most of this $600,000 is basically based on the payment of the exchange levy, which government had instituted. We are currently pursuing a waiver of this levy from government, so that we can actually apply that those funds directly into patient care rather than to pay them back into government. Along with that, we also trying to speak to government also to get our VAT exemption on our VAT. Since we are currently paying VAT on local supplies in the tune of $3 million per year, directly back into central government, and we are currently pursuing that waiver or that exemption, so that those funds again can be applied directly into patient care and into the materials and resources for the hospital. Right, next slide. The emergency ambulance service is separately funded from the QEH and has its own budget and its own head. In financial year 2017-18, we would have received $3.3 million for the emergency ambulance service, and our expenditure was about $4 million, accruing a deficit of $900,000. Financial year 2018-2019, we would receive $5.9 million, and then we would have had expenditure of 4.2. What is again interesting is that 80% of this budget is also human resources. During the year 2019-2020, we would have only received $1.5 million for the ambulance service, essentially meaning that the QEH would have carried the finances of the ambulance service from its own subvention and its own spend. This trend is likely to continue into the new financial year. As the executive chair would have alluded to, the hospital also receives funding for the medical aid scheme, which is a scheme for those persons who require medical care overseas but do not have the financial means to do so. These funds are managed by the QEH and sent to us from the Ministry of Health. These cases are approved by the QEH and sent to the Ministry of Health for final approval by the Minister. In year 2017-2018, we would have received $3 million, and then $5 million in the next financial year. As you can see, the expenditure in this account or in this fund is not spent as fast as you might expect, and therefore, this fund now currently holds $1.1 million, with about $918,000 committed to patients who are awaiting medical care, which has been delayed by COVID-19 pandemic. Overall, the hospital, we've since I've gotten here, and especially in this new financial year, we've revamped a lot of processes. We've instituted daily cash flow management. We manage our cash flow on a daily basis. We have instituted new processes to control cost. We've devolved our budgets, now departmental budgets, to executive directors who manage their budgets and therefore are responsible for the costs and the budgets that they have been assigned. And we carefully monitor our spending and we carefully monitor our approval processes have been refined, and therefore our cost management has essentially improved tremendously. We've been through this COVID-19 pandemic. It has been stressful on our finances. However, we've still been able to manage our vendors, keep our supplies, keep our stocks up, also our PPE, and we've also still been able to improve our supplies, and as Chair would have alluded to, reduce the number of stockouts which occurred during this financial year. So overall, we've seen a massive improvement in our finances and in our management, I should say, of our finances, despite the challenges that we might be having. And I think that we should see, going forward in the next financial year, we should see a reduction in our costs, especially in obsolete stock, wastage. That figure we expect to fall significantly as we use our new management information system for inventory. I think that's it for me. COVID-19. COVID-19. The first wave from April to July, we would have spent $9.3 million on COVID-19, and we did this without any additional support. This came out of our original $116 million ask, our approved budget, and then we are expecting to spend up to another $15.7 million on COVID up until the end of this financial year. That's it for me. Thank you.
Thank you, Adrian. I'm always amazed that Mr. Hurley, his 5th day on the job, he was in the well of Parliament, and now he is headlining a public accountability meeting with us. So, I want to thank him. It's not easy moving from the private sector to the public sector, but I want to commend him and the team in the finance department, because it is a process of change that they've been going through. So we began by telling you what this health system is like, the challenges that we met what we did about those challenges in terms of our achievements. Then we looked at our financial part, how were we able to finance all of those achievements and that we did. And then we said, no, so looking forward, how it is as required by the Act, what is it that we're going to be doing to address the remaining gaps? Because, as I said, Rome wasn't built in a day, and we've been on a sprint to quickly meet the public's expectation. So we recognized as we were going on, as a board, that a new strategy was needed. COVID-19 means that we have to look at new service delivery models because we have to do things differently, as Dr. Cave so often reminds us. We have to add this on top of challenges that you're aware of around waiting times. We now not only have Queen Elizabeth Hospital to deal with, we've added another mini hospital onto our area of responsibility. I always say when the board members signed up for this board, we didn't know that we were signing up for Queen Elizabeth Hospital and then eventually another hospital. So we're grappling with two hospitals essentially. We now are also dealing with human resources and ICT. As we look at all the things that we have to do, you see a recurrent theme throughout it, that we have to build the capacity of our human resources, build capacity, expand numbers, do more. Recognizing, as Adrian has said, already 60% of our budget is spent on human resources. And technology is going to be central to how we improve. And both of these areas are areas that need additional resources if we're going to modernize. We also have been very weak. I think those of you are familiar with all of the cases that have presented. Very weak public engagement, poor responsiveness to patient, and very reactive in our communication stances. So we are recognizing we have to get much more positive messages about the work that's being done. I often say that when stories pop up in the media, the people that are most impacted are actually the staff members. When you hear them in our, team meetings and our investigative panels where we look at how and why things occurred, you see team members that feel, saddened and really deeply impacted by where they feel that they've fallen short, or in some instances where they were stretched beyond their ability. So we recognize that the staff at the hospital, we really need to do a better job at promoting the great work that many of them are doing. We also recognize, in terms of a new strategy, that there was an absence of resources as our economy, as COVID has impacted our economy and people are unemployed or concerned about spending resources. We've seen a number of people who would normally seek services in the private sector coming to the Queen Elizabeth Hospital, again increasing the demand, and you saw those red numbers trending upwards in terms of people coming back to use the facilities of the hospital. We also recognize that our current governance is very much tied to public finance and public sector norms, and this is a challenge that the Prime Minister has asked specifically for us to look at how we can revisit the governance, how can we dissect these relationships and be much more agile as an institution in responding to our needs. You'll see we talked about earlier, we've sent all of our posts have to be approved by the Ministry of Civil Service, and sometimes that can be a period that can take years in some instances, which can be demotivational to many staff members who are waiting for those appointments. Or A&E, or accident and emergency, we recognize that if we build this building, but we haven't fixed the systemic issues of beds, you're going to have a situation where we have a brand new spanking building, but poor processes still leading to delays. We recognize that we have to tackle some systemic issues. So what are we doing? So we've worked on a new mission statement. We said, let's do a new strategic plan. And this is what we said we're going to do. We're going to be the premier provider of state-of-the-art quality health care, an exemplar of good corporate governance, and an employer of first choice. Our mission will be to provide professional and effective people-centered care through the optimal use of our human and resources. And we indicated what are our core values that we will be holding our staff accountable for: accountability, teamwork, excellence, integrity. And our strategy is going to be built essentially on 6 pillars. And this is what we're going to be working on over the next 2 years. Inclusion of patients and families, ICT modernization, improving our quality service delivery, having healthy, highly motivated staff, transparent corporate governance, and prudent financial management. And I'm going to be rounding off my presentation just by highlighting on what we're going to be doing in these areas. In terms of improving the patient experience, this is going to be the first pillar of our strategic plan, responding in real time to patients and families' concerns, including patients and families in decision making, empowering patients with their rights to ask questions and have those questions answered, working with NGOs and patient representatives to improve patient information and the care and support that is provided here. Our second pillar is going to be movement towards a modern digital hospital. In this regard, we're working with Honorable Minister Senator Kay McConney, MIST, and a newly established cabinet subcommittee, and how we can move the hospital in this direction, implementing appropriate enterprise solutions, upgrading our cybersecurity, upgrading our hardware, software, Wi-Fi, bandwidth, infrastructure here at the facility, and growing telemedicine and other facilities. For each of these pillars, we're going to set targets, and we're going to be measuring those targets with our dashboard that we would have given you a snapshot of earlier. The third pillar of our strategic plan for the next 3 years will be building a culture that is supportive of evidence-based practice, research, and quality measurement. We're a teaching hospital. We're a premier teaching hospital for the University of the West Indies, Barbados Community College, Samuel Jackman Prescott Polytechnic, and we're partnering with Sick Kids Toronto and other global leaders, and we really have to get this right. So we'll be strengthening our linkages with these research institutes, integrating quality improvement initiatives in all of the program areas, not just clinical service delivery, and purposefully building a knowledge and learning institution. We also borrowing a term that from Rolling Bertrand, the former general manager of Arawak Cement, when he was here in Barbados. He coined a term called peopling. And it goes back to what I talked about earlier, that you achieve everything that you do through people. And these are some of the initiatives that we're going to be doing. I'm looking to reduce rates of sickness and absenteeism, which we are measuring on an individual and departmental basis, increasing morale, staff amenities and initiatives. The recent announcement by the government of mortgages that nurses would be entitled to is something, a suggestion or recommendation that actually came from the nursing department and one of our nurses in particular. When I said to her, what would make you stay? Why would you want to leave? She says, I'm a single mother. My salary doesn't allow me to get a mortgage. We would like the opportunity as nurses to get mortgages. So we're very pleased with that initiative and at the government's responsiveness. We want to normalize the culture of caring and reward and recognize staff members who actually demonstrate it in the work that they do and that are exceptional. We want to build management capacity for leading change. Change doesn't just take place at the board level. All of our managers, executive directors, supervisors have to be equipped to lead teams in transformational leadership approaches. We also want to look and work with our trade union partners to revise the terms and conditions of service so that we can achieve a 24-hour institution and not have to rely so heavily on overtime and other initiatives. Our fifth pillar will be to institutionalize transparent corporate governance. We want to make sure we're good because we have a few of our directors that are chartered directors, very knowledgeable on the requirements of boards, but we want to make sure that we build and bake into the institution corporate compliance with our statutory guidelines, and we're going to make sure that we do that in terms of our systems, processes, and reporting, so it doesn't depend on the vicissitudes of who is on the board of directors. And part of the requirement of the Act is to maintain high levels of director education, and we would have been doing that. We would have benefited recently from Sandra Osborne, QC, doing a session with us on conflict of interest. We also, our sixth and final strategic pillar, Adrian would have alluded to, is prudent financial management, ensuring cost-effective use of available resources, maintaining up-to-date audited. Once we get out of the slump of bringing all of those audits up to date from 2011, we're going to make sure we're maintaining our audited financials up to date, that we're no longer a pariah institution for the Auditor General in terms of his continuous reporting that we are non-compliant. We want to expand our re-engineering and automation of our financial management systems and build capacity for leading change. So, having given you a broad overview of our strategic plans over the next 2 years, a strategic plan is accompanied always with an operational plan and a budget, or else it's just talk, it's just fancy talk. The way that we're going to demonstrate to you that as a board, we are moving beyond talk and just broad discussions about and pretty language about strategy is to demonstrate to you that in our operational plan and in our budgetary acts and estimates that we're in the middle of preparing, we've actually put in resources to respond to each of those 6 pillars. And I'm just going to give you a taste of some of the items that have been included in this financial year. And we think that will take us further along in the marathon sprint towards achieving. We recognize that we need more staff. You cannot be waiting 8 months for a colonoscopy, but we only have 2 gastroenterologists to serve an entire population with a heavy disease burden in this regard. Ultrasounds for 8 months. So we are bringing in additional staff. Another consultant gastroenterologist. We're bringing in more interventional radiologists. So we're bringing staff in that directly respond to the areas where we know that we have weaknesses. So it is not a scattershot approach. It is an approach that is targeted on where we know the pain and pressure points are, and bringing the staff to bring relief in those areas. Improving our patient experience. We have a quality department. We have trained staff available to work in this area. And we're going to be implementing a QEH app that patients can download on their phones and speak to our patient care team in real time about the concerns that they're having as they stay in our beds. We're also going to be improving the training of our nurses and physicians in communication of how to effectively communicate with team members. And our Patient Empowerment Committee, which is a new initiative that we would have started, is going to be equipped with a full-time resource person who's going to spend time really working on coordinating NGOs' involvement here in the hospital and helping patients who find themselves falling between the cracks of service delivery, helping them to navigate the various departments and services of the hospital. I will not say to you that these are new and fancy ideas. These are strategies that are deployed by hospitals across the globe. So we're very, very consistent with best practice approaches of tackling the issues that we're facing. In our budget, we've also, to address the issue again of policy, we're recruiting additional staff for the accident and emergency room so that we can improve the services there. We're going to be putting a client services manager into the A&E so we can have someone or two people who come to work every day to see to the needs of the clients. They have nothing else to do but ensure that people's issues are being responded to. They're part of the clinical team and can give the level of service that is required and deserved of our taxpayers who fund us. We also are going to be putting a maintenance assistance in the accident and emergency room. Very often you build a new facility and within weeks to months you see deterioration. So we want to make sure that maintenance planning is built in there. We talked about one of the reasons for delays being slow turnaround times. All of you that have been there, we're waiting on the blood results from the lab, waiting on blood results from the lab. What we're doing is buying a Piccolo lab machine and putting it into the accident and emergency so they can do their own bloods and get a quicker return on that. And we're going to be transferring patients who require our elderly for care and young for care. We're actively addressing that, and we're going to be putting into our budget resources for getting access to community beds so that we can be in a little bit more control of how we're able to get patients out of the hospital into safe spaces. We're also going to be working on the cardiology program, and you'll hear more about that, and we won't spend time there. But in terms of the Department of Surgery, we made the interventions that I said to you that we did earlier, but we're still seeing delays. So what we said we're going to do is get an independent audit done in cooperation with, we have a new head of the Department of Surgery, Dr. Sally Griffith, is very supportive of this initiative, and we'll have an independent audit done who can come and look with us at what could be the other additional issues. So throwing more staff, more resources, want to see if there are any other issues that may be impacting on delays in surgeries. And again, we're adding anesthesiologists, and we're looking to create a day case unit. Many of you who come here for small minor operations have to spend hours waiting on those little white benches outside of the Department of Surgery to be seen. And we're saying that is not good enough, not in a modern era, and we're looking to create a day case unit, ambulatory case unit, same day unit, they're called, but it all means the same thing, so that we can provide day case and ambulatory procedures much more effectively and efficiently for patients. Creating a pre-op anesthetic clinic, all of these things were put into our budget ads for 2021 to be able to improve the quality of care. We also are looking at at Harrison's Point, essentially. Harrison's Point. Yes, thanks. The Harrison's Point is an interesting facility in that although it has state-of-the-art isolation primary care for ICU patients, a lot of the patients there are asymptomatic, and we've been really learning lessons about how you provide services to patients that are relatively healthy but for COVID. So we are essentially supporting the salary of a psychologist and to be able to provide mental health checks and mental health wellness and mental health support to our patients at Harrison's Point, recruiting activities coordinators, and doing more from an amenities place. And for those of you who get the opportunity to visit there, is really, really, really a wonderful facility that is evolving, and we've put the budget to maintain that level of care. We also are putting in resources so we can better strengthen the link between the Queen Elizabeth Hospital and Harrison's Point. I'll quickly finish these just to let you know all of our areas, support services. Our budget is including working in all of these areas, support services, in creation of a telemedicine suite, doing work, continue on support services. I want to make sure, yeah, thanks. Doing our medication home delivery service, having ambassadors here at the hospital who can ensure that people are adequately spaced. There's too much congestion in the front entrance of the hospital. So we're going to be doing a lot, basically, in the area of human resources, doing a lot with peopling, providing support to the welfare. And so this morning we would have launched our Health and Wellness Commission led by Dr. Kenneth Connell and Dr. Kevin Weeks from the physiotherapy department. Basically a health and wellness program at the hospital to transform radically the environment of care here at the hospital so that it becomes a center for wellness, so that we can better tackle issues of sickness and absenteeism that plagues a lot of our staff who are impacted. And we'll be working with our trade unions. Next slide. Adrian already has spoken to the issues in financial management. And nursing, again, will be looking, the government has committed to, we're the only hospital that doesn't have a nurse that is dedicated, who comes to work every day to go after professional education and development of nurses. So we're changing that. We're creating a senior nursing officer post in this regard. And nurses here who do not necessarily want to go into administration, in anticipation that the Nursing Council will approve a specialist post, we're creating 10 nurse specialist posts here at the hospital for our nurses that are master's level trained and able to work as specialists and or practitioners. So we're adding additional opportunities for professional growth for nurses. IT is a big pillar, strengthening cybersecurity, looking at ongoing penetration of vulnerability testing in this regard, communication and philanthropy. I'm moving very quickly, but this PowerPoint will be available for anyone. Just contact us at Queen Elizabeth Hospital. Just giving you a sense of what we're doing in communications and philanthropy in this regard. In my office is responsible for legal planning, legal governance at the institution, and we're doing some work in this regard. Building, the hospital does not have an M&E department. We don't do enough on data analytics, so we're going to be building and doing significant work in this regard. Last slide. Continue down. Stop there. Revenue generation. Go back up. Thank you. Sorry, Limery, just go back to, yes. So I don't have time, obviously, to go into all the details, but I hope you're getting a picture of a board that works according to evidence and information, develops strategy, and then matches that strategy with the appropriate budget and resources to be able to do the work that we are doing. And we recognize, having been classified as a commercial state-owned enterprise, that we're therefore duty-bound to raise revenue. And so these are the areas that we're projecting over the next year, that we are going to continue with our private surgeries and fees and look to earn about $7.2 million for ourselves. We now have 4 autoclaves, so we're able to offer sterilization services across to private sector and other doctors' offices who need their equipment sterilized. We have executive medical services. A lot of people can no longer travel to Miami and Europe to do their executive medicals. We're able to do these here at the hospital and generate revenue that can subsidize other areas of the hospital that can benefit. And we're looking into the future if we can get our Lions Eye Care Center building, the third floor rebuilt, and we're working with this on philanthropy. Basically, we should be in a position to create private theater space and move private surgeries out of the main surgical theaters of the hospital. And lastly, we're looking to do a public-private partnership around building a multi-story car park in the area opposite St. Michael's School, adjoining the new A&E, so that parking, which has really been a challenge for both our visitors and staff, can be addressed significantly. Just like we're raising revenue, we found areas, and Adrian and the team seem to be an expert at doing this, areas where we're looking to save and recover revenue. And these are some areas that we are highlighting. I close by letting you know what our philanthropy priorities are. Painting of the exterior of the hospital, Lions Eye Care Center and the roof repairs there. We want to really, if people want to give to the hospital, our rehab department is in need of equipment. That equipment is impacted by significant wear and tear based on the demands that are placed upon it by the patients. We want to keep that equipment in rehab refreshed. Our cardiology services here at the hospital, and our accident and emergency department. So that was a bit of a sprint and a marathon, but I hope it gave you a full appreciation of the kinds of things that we are doing at the hospital. Are there any questions? Have there been any questions that have come online? Yes. After Dr. Cave? Okay, thank you very much. Thank you, everyone.
I'm sure on your behalf you would want me to offer appreciation to Executive Chair for a comprehensive report, of course taking us into the past, so to speak, and also what plans do exist for the ensuing year. So if you will, I will invite you to show your appreciation.
Thank you. I'm saying thank you too, because the management team and the board members are down front. So thank you. Thank all of you.
I know that we would be joined by others since we started, so again, I would also want to offer my special welcome to you. And now we will move to the presentation by Dr. Clyde Cave. I do have some comments and questions via the Facebook content, and you who are present, I remind you that you can also pose your questions. Dr. Cave would be so kind to offer now your remarks.
Thank you and good evening. It's a privilege to offer you my perspective as the acting director on some of the medical services highlights and hot topics at our hospital. My relationship with the QH goes back to when I was a medical student in 1978. That's 42 years of those of you who are doing the math. Not at the high level of the finances, thank goodness, not quite so many zeros. But I've been a medical student, an intern, a senior house officer. I was away for my postgraduate studies, but came back as a consultant, have been head of department, chairman of the medical staff committee, and now the acting director of medical services. So I offer these perspectives as we look at the hospital. Next one. Right. Major accomplishment for the last year. We're still standing. That's no mean feat for a hospital that was unexpectedly challenged by COVID, where we have seen so many other bigger and better resourced hospitals go under. We have been very lucky as being part of a national initiative where the country was well managed, but our part, our resources, our redeployments, our effects are not to be underestimated. Who are we? Fundamental identity reassessment question. You know, as an institution, as a community, we are a microcosm of the people in Barbados. Everything that you see in our community, you will see in the hospital. But also as an institution, we are an important organ of the Ministry of Health. Probably one of the most important organs and the backbone of the healthcare system. In addition to the 19 medical departments that comprise the medical services, we run educational programs, medical internship. As you know, we are sometimes bragged and boasted about within CARICOM neighbors as the number of services that are available on the public purse. And we're a favorite whipping post on talk radio and release of the frustrations of the people of Barbados in the press. For a small country, we have to try to be all things to all people. Next. One of the things that we are trying to focus on is to develop centers of excellence. And this is not in the way we talk about everything as being good and superlative, because it is the expectation of the people of this country and also of the people, the staff of the hospital, that all our departments will provide an excellent level of care. But a center of excellence comes with international recognition. We have to go above and beyond what is asked of us on a daily basis and truly produce areas that are outstanding and can stand to international scrutiny. In the Department of Pediatrics, which I know very well from being a pediatrician, we have embarked on several programs, one of which is the Shaw Center of Pediatric Excellence, which is a $10 million Canadian program which was announced at Elara Court under the patronage of the Prime Minister in February of this year. And that seeks to improve our care on many fronts. The first one being our pediatric nursing skills. So in rapid development this year, to be inaugurated next academic year, is a post-basic nursing program so that nurses who have trained at the community college and worked within the hospital now have the ability to get a postgraduate diploma in a course that is partnered with the Hospital for Sick Children in Toronto, who have international experience and have run a similar program in Ghana. The objective will be to, over the 5 years of the program, train 40 pediatric nurses to be deployed within the healthcare community in Barbados. A significant upgrade, because no matter how much equipment, how well experienced your doctors are, the bedside care depends on our nurses. The program also includes significant upgrades for our medical staff. So the University of the West Indies has a long tradition of producing specialist pediatricians through the Diploma of Medical, the DM in pediatrics. But for subspecialists, this training has to be undertaken abroad. And there are 4 opportunities over the next 5 years for pediatricians from Barbados or the region to be trained as subspecialists to return to Barbados to provide care that is not currently available. There will also be investment in quality management, risk management, systems management, and also a budget for equipment and upgrades. This overarching program will depend on many other international friendship partnerships which we've brought here. One important one is the Kids Caribbean Initiative for Childhood Cancers and Blood Disorders, which has seen one of our local pediatricians, Dr. Chantal Brown-Farmer, go to Canada for 3 years to become subspecialized as a pediatric hematologist oncologist, to return here to lead programs in sickle cell disease and childhood cancers. In order for her to work efficiently, we have to upgrade the nursing, and this has been part of the initiative in that program, but also we'll make a big ask from the hospital to upgrade our laboratory, radiation, pharmacological services. So when I say a center of excellence, it's not just a little ask, it's going to elevate the entire institution. Within our hospital, the Department of Ophthalmology has over the years been recruiting subspecialists. They are almost a standalone operation in that the eye surgeries are so specialized that they're done even in a special wing. And they have managed to have on staff, sometimes in a part-time capacity, specialists for the retina, for the cornea, for the plastic parts of the eyes, to address the multiple parts of the eye that require subspecialist treatment. In many of the other islands, if you have an ophthalmologist, a general ophthalmologist, you are lucky and that they can do what they can. We are exceedingly lucky so far to have access to all these subspecialists. There are plans to train more, and I think this department you will see in the next couple of years moving on to greater strengths. Our kidney transplant program is one that is in evolution, and quite honestly, it's a necessity because we cannot continue to pay the price of renal disease that progresses to the point of dialysis. That is a huge cost borne by the hospital and the people of Barbados. And not only for the cost, the quality of life of being hooked up to a dialysis machine is greatly improved once you can have an organ transplantation. We have some of the pieces of that already in place. Dr. Margaret O'Shea is a surgeon who has been trained in renal transplant. We have 2 nephrologists, Dr. Lisa Bell and Dr. Nersa Jarawan, who run the medical side of it. We have a hemodialysis unit which is overworked but also has in specialty nurses. We have already done a few transplants, but in order to progress this, it's not just a matter of financial resources. The first step will be the legislation to enable us to have a modern transplantation act so that we can expand the pool of donors, so that we can not only take living family members, but also public donations and cadaveric donations to expand this program. The other initiative that might seem sort of non-medical because it's not a service is the accreditation exercise that the hospital went through when it was granted a gold status from Accreditation Canada. And this is important because in small island operations, we get along by making do and think we are doing the best that we can until we are asked to examine our practices from the viewpoint of an accrediting commission from a more developed country. And that provides us with an opportunity to grow at a rate that is much greater than if we weren't asked to re-examine and rise to certain standards. That is being undertaken and hopefully will be completed next year. Regardless of outcome, though, this is a process that improves every aspect of hospital practice, both medical and the hotel function, but can only improve the services that we offer, and it will be an international verification of the standards to which we aspire. Next one. The challenges that we have, and I'm sure you will talk more, you will ask more about this in the question and answers, Let us just say that accident and emergency is a well-known challenge. The executive chair has mentioned some of those. Part of that is because of our society. There are a lot of people who come to accident and emergency that honestly should not be there. But the cultural practice is you come to the hospital expecting the best of care. The reason why that's important is because these cases slow down the entire operation of the sicker patients who need to be seen. So our accident and emergency operation will only be as successful as our partners in primary care and in the polyclinics, and also our partners within the hospital, so that once you have been assessed and treated for the accident or the emergency, you can then move on to efficient disposition back to an outpatient service or into a hospital bed. And we've already alluded to the difficulties that we're having in moving patients through the existing hospital beds. And that brings us to our bed occupancy, which for a country of this size, 500 odd beds in this hospital should be enough if we were to fulfill our mandate of tertiary care. Part of the problem is we are being asked to be more than just a secondary or tertiary care hospital. We are being asked to be a social facility for looking after people who really don't need the care of a hospital, but for social reasons who have been abandoned, or for social reasons where the families are not able to look after family members in the way that we have in years gone by, left patients here. At the current moment, I believe it's 37 patients that we have in hospital who really are not here for medical reasons. A ward has 24 beds, so 37 patients means if they were placed appropriately outside of the hospital, we would have an extra ward and a half space for patients, and this problem of moving patients from A&E and slowing them down, or not having enough beds so that we cannot admit for elective surgeries and address our waiting list, would be solved. Not as simplistic as only saying it's 37 patients, because this is a recurring need within our community that needs to be addressed. It cannot only be an ask of the Queen Elizabeth Hospital, it is an ask of our society and the entire healthcare system. The waiting times for surgery have many factors which affect them. Sometimes it's the anesthetist. Sometimes it is inefficiencies in the system which we seek to address. Sometimes it's laboratory backup. But sometimes, as is currently the case, we cannot admit patients for surgery because after their surgery, there are no beds that we can put them in, without then saying if that patient is in a hospital bed, we cannot admit the emergency that comes up through accident and emergency. So those are some of the complexities that go into what might seem to be a simple challenge to the hospital of having too long. Now, if you have a waiting list that is fully populated, once you have a cancellation, it's not as simple as saying next week, because that produces a domino effect where the next person is cancelled and the whole thing comes apart. So this is where the system of management has to be improved in its efficiency, and also our communication with our patients on the waiting list to explain what's happening, to give realistic expectations. But also we ask that the patients understand that everything that is an emergency to an individual is not always an emergency to the service when there are other people who are also in worse condition. And that's in the environment where everybody is concerned about themselves and their health. We have to get into looking, I think, a bit more broadly at the whole group of patients within our society who are requiring the services that we offer. As I said at the beginning, being all things to all people frequently comes with a price. Our cancer treatments at the hospital are at a level that are higher than so many others in the Eastern Caribbean, but still not focused in a cancer treatment unit. By that I mean that breast cancers are dealt with in the Department of Surgery. The gastroenterologists may diagnose the bowel cancers, the gynecologists, the ovarian and cervical cancers, the urologists, the prostate cancers. And then for treatment, they have to go to the Department of Radiology and Oncology, except that if it's a blood disorder, that goes to hematology. What we would like to see is to coordinate all those specialties in an umbrella that will allow cancers to have a higher level of coordinated care, which I think is a reasonable expectation for people with very severe illnesses. But as you will appreciate with a limited budget, when resources go to that, they have to come from somewhere else. And it's not an easy decision to say a person with cancer should have priority over a diabetic who might lose a limb. I will come back to those a little bit later when I talk about some of the costs that people take for granted because services at the Queen Elizabeth Hospital are free at the point of delivery, and there's a perception that the population and everyone is entitled to what they need free of cost. There are some new programs that we have been instituting. SCAN means suspected child abuse and neglect. There are overtures to make that condition in Barbados a mandatorily reported condition, as it is in North America and has been tried in some of our Caribbean countries. We know that this is a problem, the dimensions of which we can only guess at. And once the mandatory reporting comes into play, that is going to be growing exponentially, and we have to develop the resources which are not just medical, but also psychological and social worker resources to be able to respond in conjunction with the Child Care Board. So not only is this desirable as a program, it will become a necessity in the very near future. Heart attacks. You have heard from the throne speech and the executive chair's discussion that there is dissatisfaction that in a country like Barbados, the mortality from having a heart attack in Barbados is unexceptionally high. It's exceptionally high. It's unacceptable. It's about a 35% mortality if you have a heart attack in Barbados, compared with some of the other countries where it's under 10%, which is the objective of this national program. Now, a heart attack is not likely to occur in the hospital. You may be at home, so the response time from the ambulance service is going to be important. The knowledge of the people, if it happens on Broad Street, to be able to resuscitate and respond. Of the ambulance attendants when they arrive, to be able to do the right thing. For the accident and emergency to identify, investigate, and start treatment. For the Department of Cardiovascular Services to respond and do the appropriate interventions of catheterization and treatment, and then for the follow-up cardiac rehabilitation care and management of heart failure so that the disease doesn't continue and it become a revolving door. This national program that's been headed by Mr. Anthony Harris has multiple dimensions, but the part that will affect the hospital obviously is the Accident and Emergency Department and our Department of Cardiovascular Services. Now, the supplies for a cardiology program that runs a cath lab and interventional services is extremely expensive. Yesterday morning, we were at Sandy Lane, where they have donated 3 pieces of equipment for the children who have congenital heart, and that was a tune of $400,000. to outfit and run a cardiac suite is going to be a major mushrooming cost for our hospital. The bed management unit, which we have started, has dedicated personnel who will look at the inpatients, know when they are going, which beds have become available, and seek to coordinate admissions from accident and emergency department, from the outpatient clinics, from the private doctors, and from the waiting lists. This coordination has already become essential to moving patients through the hospital, and without this, the current state where we are without available beds for admission would be exceptionally worse. The Queen Elizabeth Help Desk, born out of an acknowledgement of the need to assist our clients in navigating the bureaucracy of the hospital, and really became an important tool for people during COVID, but will continue to be, and the number is there, 536-4800, which really should become an essential number, like the fire service or the Queen Elizabeth Hospital operator, for anything. They will be able to direct you towards what you need to do for emergencies, to know if you can wait, to know if you must come, to highlight the cardiac program so that if there's a heart attack, we can get onto it expediently. We're also initiating a new program of community health workers, which on the face of it might seem to be encroaching on the territory of primary care, but it has a slightly different twist. The patients identified for this program, which is a Queen Elizabeth Hospital-based program, will be those of our patients who already have a medical problem at the beginning, diabetes or heart failure or a cardiac condition, who we know are suboptimally managed in the community, maybe because they are elderly and don't understand, maybe it's social transport or family issues. Whatever it is, we know that they continue to get iller than they should and return to the accident and emergency department or the outpatient department much more frequently than they should. This will have health workers going into the homes of those selected people to make sure that they adhere to their treatment regimens, and also to early detect any changes in their condition, to have direct contact through the supervising doctor or through their hospital consultant, so that we can cut down on this revolving cycle of people being discharged, not getting better as anticipated, coming back to A&E and coming back into a hospital. There are some hot topics that I'm sure will be alluded to in the question and answer period. So I thought I would get a jump before you ask, maybe just to outline. COVID readiness. I guess my personal feeling is evident, and it's not just for the hospital. I've said it to the country whenever asked, and to my friends even when not asked, that we are not as ready now as we were a few months ago as far as the individual responsibility and awareness of the potential of COVID. This may be because we have been so lucky so far, but every country has seen successive waves, and those waves have come when people let their guard down. And just from driving around, from looking at people on the street, from number of people congregating, from seeing that the protocols for hand washing, mask wearing, and especially social distancing are not adhered to with the same kind of urgency and attention to detail as we used to do when perhaps we were more scared before we have become complacent with it. It will only take one or two cases when we identify them, if we keep behaving the way that we behave now, to cause a rapid spread within our community. For the hospital, we have put measures in place which have affected the public. Those of you who have relatives in the hospital know about the curtailment of visiting, and we have become very well aware of your dissatisfaction as time has gone on as to why you cannot come into the hospital when you want. The same thing with our clinic attendances. We are controlling the entrances. We are keeping people in a waiting area outside of the hospital in the fresh air as recommended under tents. But the Barbadian public knows how to get their way around it. We had a case the other day where it is known that the antenatal mothers are allowed to come into the hospital and go to the antenatal clinic. And this 84-year-old lady who was tired of waiting outside decided to tell the guards she was going to antenatal clinic too, and she was let in. You know, it's not really a game as to how you outsmart the guards and get in. You know, we are all in this for reasons. We are lucky that we are in a timeout where we can practice how to be vigilant and how to be prepared. But when it comes, not if it comes, that there are more cases, unless we are already practicing, we're going to be caught short and we will regret it. MRIs, very, very expensive. Part of the demand for MRIs is coming out of the change in our society. The demands for MRIs are no longer just those that are required by patients who are in services at the hospital, but also as it's become a more accepted study, people in the community who have been recommended to have an MRI by their family doctors, but whose insurance or their own pockets are not able to cover it, are now coming to the hospital specifically for a free MRI. Those studies run between $1,500 and $3,000 each. At present, we have some 50 people on a waiting list, an incredible budget, and also not always at the level of urgency that you would expect for an MRI. And this is something as an extraordinary service that we are going to have to rationalize. When you have been around for as long as I have, you can remember when we didn't have CAT scans and we got the first CAT scan in Barbados because it was the hot new equipment that the surgeons and the physicians wanted to be up to date and make a diagnosis. And the chief medical officer at that time declined to fund it, Dr. Lenore Harney, because she said until every household in Barbados has an indoor toilet and running water, to spend that investment for the few cases was not something she could support. That is an essential conversation that we have to have when we rationalize our services. You know, getting everything for free as seen on American TV is probably not something that the country can afford, and certainly not something that the Queen Elizabeth Hospital Medical Services can provide. I wanted to spend a little time on the freeness because a lot of the people coming in now making their own demands with the perception that we are standing in their way of something that they're entitled to, and really we should have no concern about it because we don't have to pay for it. You know, you heard that we have like 16,000 people who come into hospital a year and near 100,000 people who use our outpatient services and some 40,000 people a year who come through the accident and emergency department. Somebody has to pay for that. When you are one of those people, you see it from your individual perspective. Perhaps as a community, we should be aware of the number of people who are also using the services. For example, we're seeing more people coming for chemotherapy for cancers. Even people who have not been diagnosed or treated in the hospital now come when they need medication. If you have breast cancer, A 6-month supply of one of the newer drugs is between $17,000 and $25,000. And if you have colon cancer, it's $28,000. That's something that comes out of our pharmacy budgets. It's not for free. The waiting lists for joints, the hardware, not the time in surgery or the surgeons. It's for hip, about $3,000 for the hip implant. But you can't just have one implant per patient because you don't know what size it's going to be required. There are 7 sizes that have to be available in the stock room. So we have to have $21,000 worth of equipment sitting down there before you can have your operation. And if you have an operation and you go into the operating theater, to run our operating theaters, that's $3,900 an hour, almost $4,000, and a hip replacement is going to take a couple of hours. $65 a minute is what it takes us to run those operating theaters. And then if you need to go into a bed on our general ward, to provide the services that accompany that bed, and I'm not just speaking about the cost of the bed or the housekeeping or the linen, the maids and orderlies who move you around, the nurses who are there 24 hours, the medication that's supplied to you as needed, the doctors and specialists who do the operation and provide the ongoing care. That kind of works out to us at about $550 per night, which is a pretty fancy hospital cost. But that's if you're on the general ward. If you are in the surgical intensive care unit, because there was a complication with that operation, that's something like over $2,000 a day, slightly less if you are in the medical intensive care unit, which comes out to be just over $1,000 a day. One of the things that we do is an obstetric service. We provide care for anybody who comes to the antenatal clinics and comes into the hospital as a public delivery. Our pediatric service looking after premature babies is something that is known that we have gotten better at, which is a very good thing. But for a small baby who is born prematurely, and some of those babies can stay in 2, 3, or 4 months, the cost in our NICU is about $700 per day. If you stay in for 8 weeks, that's $42,000 for that premature baby just to be able to go home. We have about 50 babies a year who are under 1,500 grams. So the cost to say that in Barbados, if I have a premature baby, it will be looked after at the hospital, and isn't this wonderful, is a bill of over $2 million to our budget just to be able to run an NICU to look after very small babies. The point I'm making is that freeness is not really free. It is just that people are not paying for it at the point of utilization. And I think we should be more cognizant of what goes into the services that we take for granted from the hospital. The last thing I had wanted to mention about was the dialysis service and the privilege that people in this country have of having access to a public service through this hospital that can provide dialysis. You travel to any of the other islands, if you have renal failure and you have no individual means, your death is coming much sooner than it would if you lived here. We currently have about 192 people in our renal unit here. And that's not including the ones that are having peritoneal dialysis, which is a system where we can do the cleansing of the blood at home through putting fluid into their abdomen and taking it back out to work like a kidney. If you need the artificial machine, that's 192 people that we have in the hospital. But the demand has grown so much from 50 in 2017 to 125 people that we now outsource at over $160,000 a month. which means just in the outsourced services, in those 125 people who we cannot look after in the hospital but who need dialysis, we pay out $4.2 million a year, which again has to come from somewhere. So for those people who use the hospital, your demands for quality are important and should be met. Every Barbadian patient deserves the best. But it cannot be that the expectation is for unnecessary services, unfair services, or services which will not be honored. So in order to help us to provide the very best tertiary care, it is really important that the health in the community at the primary level, which means the families, the diets, the obesity, the healthy lifestyle, the early detection at polyclinics or private doctors, the adherence to medication, those partners have to work with us so that we can provide the tertiary high-level care that we wish to and which you deserve. So I'm happy to take questions as they arise. Thank you.
Thank you very much, Dr. Cave, and you will have heard from both Dr. Cave and Executive Chair. So now it's your turn to pose questions or offer some comments. I do have some via the Facebook connection, and I would want to certainly at this point in time thank those persons who submitted their questions and their comments via Facebook. I also would wish to offer two comments that came via Facebook. One was from Velda Welch, and her statement is, or rather her comment is, a multi-story car park would be welcomed. So that's a good start. And then another one from Patricia Stanford. Barbados' healthcare is moving in the right direction. Healthcare operations can be complex, but with their dashboard, the focus on each area, with the incorporation of best practices. From you, the audience present, do you have any questions or comments? The microphones are placed on both sides, so you can use them as you offer your comments. And we do let me remind you that if you wish to offer a comment to any of the individuals present, just mention names so that we know that question is directed to whether it be Dr. Cave or Executive Chair.
Hi, good evening. I look forward to this every year. I only missed one since it started.
Just not interrupt you, but the volume.
Yeah, I've only missed one since they started, and they're always very. Okay. Yes, and I have a whole load of questions, but I will limit my comments. First of all, before I forget, Ms. Sutherland, you had said that you can get your presentation.
Yes.
Will it be online or?
Yes, it will be online, or you can write us at feedback. Email us at feedback at qeh.gov.bb, and we will send it to you. But we will put it online on our website.
Yeah. I just want to limit my questions because I have a whole load of questions and comments and so on. But fundamentally, I would comment on Dr. Cave comment of Barbadians' concept of entitlement or demands on the system and so on. And I'm one of these people that feel that a nation is valued by how it takes care of its people. And I think that over the years, Barbados have tried to do that. From the presentation that and the finance officer that have done is that despite, but you say we are still standing, despite everything else. So my question to the finance person was when he was speaking to the accident and emergency services, I couldn't see it very well, but I kept looking for maintenance. And I'm saying this within the context of somebody that passed the main road there the amount of vans that I see there that seems not to be in functioning. And this is an area that I want to hear, like how the hospital, you mentioned it in terms of, I don't remember the phrase you used, how the engineers do something.
Preventative maintenance?
No, when they pull and pull.
Colifox.
Colifox.
Yeah, it's a QEH word,
right?
yes.
And I know that Transport Board does that, and I wonder how efficient it is, as opposed to a well maintenance program, which I didn't really see coming out in the presentation.
Yes.
In terms of how maintenance is a major factor within the budgeting. Right? So that's something that I would like to hear. And the other comment is the whole question of, I like the introduction of the care. I have a friend who is a cancer patient here, and I tell you, part of her wellness is this whole question of how to take these drugs. They got these tablets, they got appointments, she kept forgetting one appointment, then to get another one. So I think that that intervention is important. Right, so the last one, like I said, after a while I stopped writing down because I was so enthralled in the presentation and the strategic plan and visioning important. And just Dr. Sutherland, I would just like you to repeat to me the new vision statement and vision statement, because it seemed to speak to me in terms of how within the rising costs and so on. And another area that this is a pet peeve of mine, and I don't know if it was addressed. I came a little late because I thought it was starting at 7. The structure of the hospital, and something that I'm afraid of, that is part of the complaint that I hear Dr. K speaking to on the radio and so on. This whole question in the quest for the hospital to raise money, how the public-private concept is, how is it going to maintain that equality of service, especially to the public person? Because I'm very concerned that whenever there's private-public ventures, the public part of it is the one that is always not part of the equality situation. I will limit myself to those words there. Thank you very much. And
Can I clarify? The first question you were asking about the ambulance, broken out ambulances out by N4. That's what you're asking about?
and how, what's the maintenance? Okay.
The ambulances that she was talking about.
Within the presentations, I think
Yes.
a maintenance
We have
concept.
maintenance. Yeah, we have maintenance in the budget. Yeah.
Okay, just let me address the ambulances across the street. Those ambulances are end of life. Yeah. The hospital, so therefore the hospital's policy is to replace their ambulances once a year. Buy a new ambulance every year. We're trying to get to a place where Paula could correct me, where we have no ambulance over 3 years old. That's where we want to get. We want to get to a place where they are not all coming to end of life at the same time, which is a thing that you see. Sometimes you probably would have saw it at the Transport Board, or you would have saw it at Sanitation Service Authority. We're trying not to fall into that category where all of our ambulances are at end of life at the same time. So in this last year's budget, we bought one in this financial year, and we've budgeted for another one in next financial year, and we'll keep doing that to ensure that we have that our ambulances are always in good shape, and none of them are older than 3 years, due to the number of the kilometers that they do. Jessica.
Yes. Thank you very much. Can you hear me? Hi, yeah. You're correct. You actually have a very, where are you? You have an eagle eye, because I realized when I look back through the presentation that we missed a slide that talks to engineering services. There's medical there, there's human resources, So it was not emphasized. Although it was moving quickly, I can't use the excuse of moving quickly. I actually missed it. So you're correct. It is an area of focus because engineering covers the equipment. The engineering department is responsible for maintaining all of those equipment. So part of what we're investing in over the next financial year are two critical areas. One, recruitment of a project engineer so that we can do our projects more efficiently and effectively and not have cost wastes. And two, we're increasing our maintenance budgets. We've devolved it down to department level, and we have increased our maintenance budget. You remember the amount, Adrian, a rough percentage? About 30%? About 30% or so we've increased our budget by that amount. So you're correct that to keep this plant operational, we have to invest in maintenance and repairs. We also have to invest in preventative maintenance, particularly of our biomedical equipment. And we have to have staff. We do a lot of projects around this hospital we want a combination of project engineering, quantity surveying, so that we can have a much better handle on how we manage projects, how we cost initiatives. And so that is the intervention we're going to be making on maintenance and repairs. I'm so glad you raised the issue of your friend with cancer. And the challenges that she has is an area that is of special interest to myself. And we have started a patient empowerment committee. It's actually chaired by Antoine Williams here. And I'm actually hoping you will stay back and join us to be part of that committee so you can be actively involved, since you have to come to every meeting for these 7 years and not miss one means that you're interested and you're committed. And just from the questions you're asking, you're the ideal kind of person we would want to be participating with us in that committee. But part of the remit of that committee, which involves individuals as well as organizations like Cancer Support Services, Heart and Stroke Foundation, is that we recognize that the institution is weak in terms of care and support for people who are impacted by various illnesses and cancer in particular. Cancer Support Services does a very good job, but if the person is not linked to support services, then they're not good necessarily, they may be struggling. So we recognize in order to meet the needs of our patients, it's not going to be enough to provide the nurses, the doctors, and the treatment, that we have to do more. We have to teach them how to cope with the disease. We have to teach them how to have family members understand and be supported to in turn support the patients. A whole regime around patient empowerment we have to implement. The issue of public and private, you're correct. We do rely, it is a dual system, as I said earlier, and we rely on the private sector to help supplement the cost. I want to thank the University of the West Indies, St. Augustine campus, for providing us with a costing study that allowed Dr. K to speak so eloquently and allow us to understand our costs. That awareness of the costs helps us to understand that the state alone cannot meet the demands that are being placed upon the hospital, that we have to generate revenue for ourselves. But it's really a matter of having the right policies in place to ensure there's equity and equality in how people are treated as an institution. Lots of hospitals grapple with this mix of both public and private. We have to ensure that all the ethical practices are in place so that physicians who are moving patients between the public sector and the private sector and back are doing so within ethical frameworks, that there are no conflict of interest embedded in how referrals are made from the hospital, let's say, to the private sector. There is a lot of work that has to be done on governance around this issue to make sure that we get it right, that no questions of inequality arise. One of the strengths of Barbados, one of the things that we can be proud of as a country, is that we have a system that really treats with ensuring people have equal access. But the reality is, the way our hospital is financed, that we're going to continue to need that model of private sector cases coming and occupying our private suites and purchasing services from us to be able to generate the additional revenue that we need to do the things that Dr. Cave is talking about, like expand the number of dialysis. So we have to grapple with it through our governance and our financial management systems.
All right, thank you very much. And I would also like to thank...
The vision statement, she wanted me to read.
Oh, yes.
Yeah, to be the premier provider of tertiary healthcare in the Caribbean, an exemplar of good corporate governance, and an employer of first choice. That is our long-term vision. And how we're going to get there, our mission is that we're going to do that by providing professional, because that covers how people work, and cost-effective, patient-centered care through the optimal use of our human and capital resources. So all of these thematically speak to all of what you see running through our strategic plan, being state of the art. Those are the kinds of initiatives.
That's your response.
You're welcome.
All right, any other questions from the audience? So they do have a number of questions and comments via Facebook, so I would want to attend to those. If there are none in this, no questions from you? All right, so I'll bring some questions now that were posted by our Facebook Live audience. And these, well, there are two questions that really relate to the same topic, and that is in reference to parking. I know in your presentation you did make some reference to that, so perhaps for the purpose of a reminder, you can answer the questions, what is being done to address the issue of parking for visitors, and the other question speaks about the same thing. And this one relates to, now that the hospital is in construction period, what is being done to accommodate visitors?
Okay, thanks. Parking. We recognize that parking is a serious issue. Even before we started the accident and emergency project, parking was severely constrained. People are parking all around the facility. They're parking across the road in Delaware land. They're parking illegally on our compound. The Best of Santos lab has kicked Queen Elizabeth Hospital staff out of their car park because they're level 3 lab, and they need to ensure that they're maintaining the standards that are required of a lab. So we've recognized that in order to do this, we need to build a car park. But we're trying to do so strategically. We want to do that with a public-private partnership using a bolt type arrangement: build, operate, lease, and transfer. Because we think that's the best way to approach it. So within the next few months, we will be putting out an expression of interest for people to come. Because it is not our core area of work, we see no need for the hospital to get into the business of running a car park. But what we can do, use the fact that we have land that has been ceded to us, use the fact that we can partner officially as a government entity, and our infrastructure committee headed by Joseph Lafloof is going to provide that leadership in trying to get that car park going. We think there will be definite interest because the volume of people that pass through here, based on the numbers, which now that we have our pamphlet we can show, means that it is going to be definitely a good business proposition. In terms of the other area is, did I answer that fully?
Yeah.
Okay, thank you.
All right. Here's another comment, or, well, question really, from Venicia Carrington. Waiting is too long when you have to see a doctor. That's really not a question. A bold plain state.
Yeah, is it for, she didn't specify A and
No,
A&E or where?
there's no indicator as to which
Yeah.
area. Just simply waiting is too long when you have to see a doctor.
Yes.
Well, the intake to the hospital for patients would be emergencies. Okay? As I tried to say, when you have to see a doctor from the individual, is perhaps a little bit of a judgment call. So calling the help desk first to find out which doctor, where, and when might be a good start rather than just coming to the accident and emergency department. Now, if you show up at the accident and emergency department, there is a triage process. Triage means that the professionals there determine who is the most severe and urgent and who can wait. In addition to that triage with COVID, we have another layer where you have a COVID questionnaire to determine COVID risk. But even without COVID, if you have a problem which is important to you, but not urgent, life-threatening, and something that could be seen somewhere else in the next day, we will see you because we have to see patients who show up. But really, the person who is more urgent will be given priority. And it's not just that because you came and there were 17 above you, you are going to go in at number 18. That's going to be constantly reassessed as more urgent and emergency cases come in. So first of all, determining where you should be at, if you should be at accident and emergency department. Now, yes, there are long waiting times on occasion. There are times when, our triage is usually good. Within a very short period of
15
time,
minutes.
they will know who you are and what you need. We do, I think, very well with international standards for the people who have had trauma, who are bleeding, who have an acute emergency. The ones who are less emergencies take longer because sometimes the holdups are getting them onto an appropriate site. Sometimes it's doing the investigations but getting back the results before action can be taken. But that first encounter will always be at triage. And if there is an issue with the demand for care, that should be raised at that time. There are even patient advocates in A&E, and as you heard from Executive Chair, we're looking at the equivalent of a front of house manager who will address all these systemic, urgent, registration, perception kind of issues. Now, if the question is coming to an outpatient clinic and taking too long for your appointment, this has been really difficult for as long as I can remember. My internship in 1980 was with Mr. Michael Clark, who was a surgeon well known for being a stickler and wanting to have an appointment system. Barbadians still do not stick to an appointment system. The people from the country come in on the first bus, and that might get here at 6:30 or 7 in the morning. And whether or not they're given an appointment at 10 o'clock, that's when they are going to come. When you're trying to control people density and number of people in a clinic, under COVID, that's really going to be difficult to accommodate. So we have been working on an appointment system to get people in at specified times. Now, there is a slow response, a slower than needed response sometimes, because when seeing a patient, you need to have access to not only the medical record, but any investigations. And until we reach the part in the strategic plan where we have an automated electronic medical record with everything online, we are still dependent on an older system where results will not be available. And when you have a holdup at 8 o'clock, the patient who comes in at 9 is also going to be slowed down, and then it cascades from there. So there are two issues with her question. One is the time and the outpatient considerations, but the other one is the quality of the service. Now, I would like to think that we can do both, but if there has to be a focus within our resources, we're going to have to make sure that you get good quality care rather than just convenient care.
Thank you very much. Can't get your surgery done as some equipment is not working. When can these be fixed so people can get their surgeries done?
That's a very broad question because there are so many different kinds of equipment involved in surgery. We don't know when there is going to be a malfunction, even if we were able to have the best of maintenance plans in place. If the challenge is right now, I can share that since COVID restrictions, the delays are even longer because sometimes to repair equipment means bringing in an overseas technician, and it's not easy to jump on a plane and get access into the country and then into the hospital and back out the next day that it used to be. Okay, so there are constant challenges, and we have to be a little bit more specific to be able to answer what the individual delay was.
But could I also speak to that? But that is why I was at pains to stress the investment in equipment and to provide the level of graphic detail, because we recognize that has been a problem. The status of equipment leading to delays. So I think we're very pleased that many of the service areas now have appropriate levels of equipment. The challenge we have that Dr. K was speaking to is that other pieces we have to make sure we're able to get the overseas technicians in within the COVID restrictions to maintain the existing equipment that we have as well as the new pieces.
All right, thank you. I'm trying to accommodate the many questions that have been posted on Facebook. Some of them reference presentations done by both Dr. Cabe and the Executive Chair. So I'm trying to ensure that we accommodate the questions that are being posted. Are there any other questions from the Facebook post? Right, and that's one of the, I don't want to say demerits of going live, where you just can't stop persons from posting. But for the purpose of time, I would want perhaps to, if we can control that. If not, we'll probably be here till midnight. I know that persons have lots of concerns and issues, but we also have to appreciate that there will be a need to have similar events of this kind.
Yes.
So we can have an opportunity for persons to openly, or rather to offer the open questions, because some of these are not directly related to today's experience. But I'm going to offer this one now. And the question is, does QEH plan to introduce a hospital equivalent ISO standard? A strategic plan is usually long range in nature, and the period of 2 years is too short to effect any meaningful change.
Yes.
It's 3 years.
Yes, it's 3 years. The strategic plan is 3 years. We do have, we are accredited as a hospital by Accreditation Canada, and that is a body that sets our quality standards, and we are accredited at Gold. And in addition to Accreditation Canada, our kitchen is also accredited by HACCP, and our lab is accredited by JANAC. So we have a very strong quality and standard setting regime across the hospital, and we're due to go back into our next cycle. We do not use generic, ISO type standards. For hospitals, locally, you really go for hospital-based accreditation bodies like Accreditation Canada, Joint Commission, those kinds of standard-setting bodies, rather than a generic standard setting.
All right. this next post relates to services. When will you ensure that the rehabilitative services are improved to meet the needs and demands of persons with serious impairments and disabilities?
Rehab. The chair of our patient care committee is actually one of Barbados's top rehab professionals, Dr. Jackie King. So she always takes a special, she's here with us this evening, takes a special interest in this area. I think the reality is, Dr. King will tell you, is that the service that we have is really trying to stretch way beyond the capacity of the number and staff and capacity. And as we have an increased number of strokes, really what is required is, I think Jackie would use the word maybe an overhaul or a significant expansion. Jackie?
I would say that we want to look at, yes, an overhaul and expansion of services, and maybe a decentralization of
Yes.
services, so that we can get services into the polyclinic, so that everything is not bottlenecked.
Yes.
And expect to have service here.
That's an important point. So that is something that Dr. King keeps stressing, that is not, we need to take a health systems approach to this, that if we can strengthen rehab services within the polyclinic setting, that it will help decompress the demand for services. But right now, I know I speak on behalf of the rehab team, all elements of it, this service is significantly oversubscribed. So it's a legitimate concern.
Yeah. Are there plans to upgrade the training of ambulance personnel?
Yes, they are. Yes, they are. Shani has gone through the door. Dr. David Byer and the team that's leading that department are really focused on this as the strategic direction for where the investment in the next financial year is going to be. The cardiology project that we talked about will bring not only expanded levels of equipment, such as defibrillators and everything that people see on television in terms of first response by ambulance physicians, but we recognize that we also have to train our ambulance personnel to be able to provide that level of first line care. So the answer is yes, and it is in our budget.
Okay.
For us, it's important to what an institution values by what it invests in. So the answer is yes, and it's in our budget.
All right. Will Barbados have a case management program?
Yes, we have taken some baby steps in terms of our bed management unit. Case management, for those who are not aware, in North American, Canadian, UK hospitals, there are a group of professionals who work as part of the care delivery team with doctors, nurses, rehab professionals, and work either unit or ward or service specific and really ensure that the patients are getting. We haven't had the resources to be able to expand at the level that we would like. So what we're essentially doing is using our bed management team. They're doing a combination of bed management and case management. In order to get patients out of the hospital, they're going to have to do that. But it is not a full case management system as you would see in North American facilities, but I would say we're about 20 or 30% there.
I know that Dr. Cave spoke a lot about the cost that is involved as far as the patients, housing patients, and taking care of them. And this question, Dr. Cave, I will pose to you, and it is posted by Valerie Rock. It says the EMS personnel should let persons that are involved in accidents know that they will be billed by the hospital when they are treated. I don't know if you can answer that, or that's again another broad question.
So I'm not sure about billing. Every citizen of Barbados is treated free at the point of care. If there are visitors to the island who or people who are passing through, different things apply to billing for hospital care, but it's not the practice to discuss money when you're bleeding. That's not part of our culture. So putting the finances, before the medical care in an emergency would not be something we would do. But as we did say, money drives the services that we can offer. So if you're not entitled to it, yes, there will be a charge that the hospital is entitled to correct.
Yeah, Adrian can speak to this because I think it relates to insurance and cost recovery on the part of the hospital. Adrian?
Correct. A policy decision was taken a few years back to bill persons, because of the high level of vehicular accidents, to bill those persons involved in the accidents to recover the cost of treatment, to encourage those persons to help us to recover that cost from the insurance company. So that's what, and that bill doesn't go directly to the insurance company because we wouldn't be aware of who that person's insurance is. So we would therefore bill the patient. So that's why that person would have received a invoice from us.
Yes. Yeah, I know that this is something I think the last administration was doing in order to improve our financial intake, basically by trying to recover costs from insurance companies, because insurance companies would pay every other service delivery. They pay for medical reports, they pay the private physicians, but the hospital would not be paid. So I think that is where that emerged from, and we think it is reasonable. So what we're encouraging the persons to do is really to seek to recover the costs from the insurance company.
All right. Just for our Facebook audience, let you know that if you have any additional questions, they can be posted at feedback@qeh.gov.bb. It has been, sorry, it's the handwriting. What has been done at the Arch Hall Fire Station? Are there any future plans of having ambulances assigned at other fire stations? Or as it has been done at the Arch Hall, the question is if there are plans to have other ambulances assigned.
Yeah, Shani's not here, but I'm going to attempt to answer that for Dr. Bayer. Dr. Shani Williams from the emergency. Shani, there's a question about if there's additional plans to post ambulances in other fire stations beyond Arch Hall. If you could come down and we're not sure. We're hoping that Shani would be able to answer that as she's part of the Emergency Services Directorate.
It is not a finalized plan. That's a conversation that we continuously have to decentralize ambulances throughout the island, and the logistical, the easiest thing to do would link them with the fire service, as well as an option of having roving ambulances throughout the island so that we can improve on our response time. So Arch Hall was a plan, 1 in 6 roads was another plan in progress, but it's not a finalized plan.
Okay, so it's something we're about to enter into a memorandum of understanding. The draft has actually been worked through between ourselves and Chief Maynard and the Barbados Fire Service, and we're looking to work in closer collaboration with them. So we're going to try to tackle some of these issues. So it's a great question and something that we need to do in order to modernize emergency services.
Okay, thank you. I just have a few more questions, so we'll wrap up shortly. And this is not like the usual Bajan term when you say, I soon get there, and you're waiting for a whole hour. So fear not. This question relates, and as I said, some of the comments about, or some of the answers to these have already been clearly outlined by both Dr. Cave and Executive Chair. Patricia Stanford says, what are you doing to decrease your readmission rates?
Yes. Well, we have the community health workers project, which is underway. We're in the process of training persons. 40 people will be deployed to work with patients in the cardiology, diabetes, and hypertension clinic. And they will be working under the umbrella of the social work department and Dr. Russell Broom Webster, and basically follow people into the community to reduce readmissions and improve discharge planning.
You know, I think this, Antoine, is part of the health conversation. And the Bajan public has in many ways become passive with their health. The way that question is posed, what is QEH doing to prevent their readmission? Part of the discussion is, what are you doing to maintain your health so that you don't come back into hospital? You know, and that communication and facilitating it is certainly something that we have to work towards. But I think it's a bit unfair to say to a country, to a government, to a hospital, to a surgical service to say, we are not going to watch our diet and exercise. We are going to let our tendency to diabetes run rampant. But what are you going to do about these amputations? You know, it's a conversation that we have to engage in from both sides.
Thank you. Question of staffing. This one relates to the X-ray department, and Angelique says, my ultrasound appointment was cancelled and I can't get an appointment before next year. And again, I know that there was some reference in your presentation.
You said about 8 months.
Yeah. You know, ultrasonographers internationally are in high demand. We have tried. It's particularly difficult now to bring in any kind of ultrasonographer specialists if we could recruit them and they were willing to come here to get them into the country. We have trained local ultrasonographers, but because of the demand elsewhere, they have moved on. It's not something that we currently have a training program for, and in a case where there's an international demand, maybe this is an opportunity for one of our partners to address. We have been assisted by the government of the People's Republic of China in providing us with, ultrasonographers. We have attempted to address the obstetric ultrasounds by having our obstetricians in training, where that's one of their skills, actually provide a service of doing the obstetric ultrasounds. But yes, we recognize that there is still a demand greater than what we can supply. This is one of the few cases where we do have available posts, so if there's anybody there who's an unemployed ultrasonographer and would like to work here, we're welcome to receive your phone calls.
All right, this next question, moving along. There are two, both I can treat as one. I'm asking if there is not any more space where a block of wards can be built. And then the next question is, there has been talk about the need for a new hospital. And is the QEH in a position to properly service the needs of the country? Or is there indeed a need for an additional hospital? I know you made reference to Harrison Point.
Yes.
So how would you want to treat to that?
If we are dreaming in a world where money does not matter,
600 million.
space does not matter, relocation of traffic patterns, demand doesn't matter, sure, we'll have a new hospital.
Easy so.
And then we'll quarrel about what needs to go into the hospital and if we can afford to run it if we had it. It's a difficult balance. This is what we have, and we have to optimize it. You know, when bigger funds become available, yes, but for the time being, this is where we live, this is what we have, and this is what we must make the best of.
Yes.
And just on the issue of beds, I think the bed number basically is really very scientifically worked out based on population size. So I think the big issue with us on beds, as Dr. Cave said, if we can really remove our elderly for care and or young for care and social cases, we can do a much better job of getting people. If we can improve the efficiencies you saw from our dashboard in the Department of Medicine, we can have a stronger throughput. So I'm in agreement until we have the resources. I think a new hospital is something like 600 million. I think that's the kind of nearly $1 billion. Yes, thank you. I'm aging myself. So we recognize that we would have to have a significant investor coming to the table with another, with that type of engagement is not beyond us, but then a whole other discussion comes once we have that hospital, what goes in it and so on and so forth. So right now I'm with Dr. Cave, and I think, or as a board, we're looking to optimize the facility that we have and why we're investing so heavily on plant and equipment and repairs and making sure that the staff who are working here get the kind of conditions of work and the patients have the experience they need.
Unless there's somebody out there with a spare billion who would like to give us for a new hospital. But the reality is, if we were to start now and funds were not a limiting factor, it would still take a while to design and build and operationalize. And we can't give up on the hospital in the meantime. So regardless of that wonderful dream, we still have to work with what we have as best we can.
Thank you. Just getting down to the wire now. This one relates to the questions of meals. And it says, I've had the discomfort on several occasions to watch the kid. That's not case. To watch meals being served to all patients, whether they are diabetic, have cancer, or a broken leg. So the question is, how will the procurement team satisfy the need and make sure that they are not providing patients with the same meals? And they're suggesting that perhaps they need to shop around for suppliers.
Yeah, Louise is going to answer that. I said to Louise will be the first hospital administrator to get a Nobel Peace Prize if she can resolve this issue. But we have a number of initiatives underway. This is, Louise is going to speak to this because she's been working on it.
So, I'd like to dispel a few myths and to share some of our plans that we have for the improvement of the meal service. So, when a patient is admitted, a person is admitted to the hospital, and particularly for those with great acuity of sickness, the first order of business with respect to their treatment, or one of the first orders of business with respect to their treatment, is that the doctors sit with our clinical dietitians to determine what the therapeutic nutritional needs are of the patient. And based on that, they will develop a diet order. So, and that diet order, the principle of that is good nutrition and the administering nutrients that help to bolster the person's immune system and their health system. So particularly with those who are acutely ill, unless you are qualified as a clinical dietitian, you may look at the meal that the person has been given and determine that it may be for a diabetic and it's too much calories or too many carbohydrates. But that is exactly what the nutritional needs are of the patients at times. Where we may become deficient in that is that for this entire hospital and this acute setting, there are only 5 clinical dietitians to serve the hospital, and in fact in most of the country. And we may not always be able to get to every single patient to monitor the diet order that has been prepared for that patient. Our intent now going forward is to create a service that we are able to deploy aides, what we like to call them our meal ambassadors, to go to the patient's bedside and to provide information on the meals that have been ordered for them, to close any gaps or mistakes that have been made in terms of the diet order. We are also in the process of implementing a technological solution for improving the meal service, where meals are prepared by recipes and persons are able to order. Those who are not acutely ill can order the types of meals that they prefer based on the diet order and the salt and caloric and carbohydrate intake that is necessary for their healing. And also to look at the presentation of our meals. We are, by the end of this financial year, we would have recruited a what is equivalent to a food and beverage manager. We're calling it a head chef, who will have a direct input on how the meals are prepared, their presentation, etc. And creating that dialogue between the patient and the food service, the food services division, to provide that information on the types of meals that have been ordered for them and why they've been ordered for them. So we are not at 100% where we would like to be, but I expect within by the end of the financial year, or within the next financial year, we would have made a significant improvement in our meal service.
All right, thank you very much.
Harrison's Point already has a chef there, and we're looking to have a similar person down here that can provide leadership. We're separating the kitchen from the clinical dietitian service and really look to modernize our whole approach to delivery of food, menus, and presentation. And this is a big task for whoever is selected. I think we're in the process of recruiting, Susan. We have several applicants. I think the downturn in the tourism marketplace has redounded to our benefit because we've gotten several extremely strong applicants. So if we can get a very, very strong chef with good culinary, kitchen management skills, who are used to working in big settings, we should do very, very well, because there will be a subset that still need your soft diets and still need that strong clinical input, but we can do better as a service. So thanks, Louise, and real leadership is happening by Louise in that area.
Yeah, thank you very much. And if I may, just offer a comment. I know that, and this from my own experience, persons are always quick and eager to decry the meal service, and their families also contribute to it. And I remember one time I was here, I had just gotten a surgery, had to remove some kidney stones, and there was this gentleman who was a diabetic, at the time, and he had this daughter, I think, that would come into the ward every evening with her flask. And he would always boast about the different things that are mixed up in this flask, until one day the nurse said to him, you should not be doing this. And he said, well, I want the hospital food, I don't want that. But she said, but what you're doing, you're really making the situation worse, because whatever is in that flask, we cannot monitor it. So you get situations like that. And certainly for me, I recall when I was here doing chemo, I just had an urge to eat chicken barn. For some reason, I just did not want whatever was presented to me. But I like the idea of monitoring and certainly complementing the individual patient's concern. I just have two more questions, and Dr. Cave, I'll pose this one to you. And this may be, this is an interesting one. Why is it that staff, Why is it that staff has to wait hours before seeing a doctor?
Staff.
Yeah. And then,
That is a piece you should
of
answer.
course, the last question.
That's an interesting question, and there are many aspects to it. It depends on what is wrong with the staff and where they are waiting. We do have a staff clinic that all our staff have access to for if they are unwell while in hospital. But there is sometimes a perception that if a staff member, or sometimes even their extended family, becomes unwell at home, they should have priority if they come to the Accident and Emergency Service or anywhere else, that there should be a priority line for them. With the stress that our Accident and Emergency Service is under and with our staffing, that's not something that we can offer. There's also the aspect of it, I think, where when staff have easy access to a hospital service preferentially, they don't appreciate what the regular Barbadian has to go through to access that service. And I think they always told us in medical school that until you become a patient, you'll never appreciate what the real role of a doctor is. And I sometimes think until you have a long wait in A&E, you don't appreciate what the long wait is for your patients. So in an ideal world, I would like to think that the service we offer to all our patients would be of such a standard that no better could be done whether you were a member of staff or not. You know, the reality of providing a different service for some people and therefore taking it from the regular service, I am not sure if that is something we would want to encourage. But I don't know if that answers all aspects of the question, because at a time when there is a me generation, everybody's looking out for what is best for them. And as an institution, we have to make decisions as to what is best for the community.
The only thing I want to add in this regard, because I always said this is an area that I enjoy working with the management team. This is an area that I think the board and the management team of the hospital have been at slight variance, because I think it has been a board mandate to create preferential access to staff, certainly to the accident and emergency room. And I know there's been, I can't even call it passive aggressive resistance. It's just been, as Dr. Cave has said, it's just something that A&E has said continuously that they can't do. For me, the challenge is that then we have to find a solution, because it's very difficult for people to work and give the level of commitment to an institution when they themselves or a close relative has an illness and they feel as if they're not being, that their colleagues are not giving them the kind of level of support. So what I've been saying to Dr. Cave and others is that we have to look at our staff clinic, we have to look at lengthening the hours, we have to look at some sort of internal arrangement for staff who get sick, after hours. During the daytime is fine. The real challenge we have is after 4:30 and on weekends, and so it really is a work in progress that we have to find a solution that works. And my hope is by providing A&E additional staff, new facilities and amenities, that we should be in a position to really look at how we treat with this issue. So it continues to be a healthy area of variance between the board and the management of the hospital, and being in the middle, I have to carefully navigate that space, because I do understand how staff members feel.
Thank you. Our final question, I can only but describe this one as provocative. Why is it that the gentleman who has the monopoly for making these antiquated limbs for persons with amputations is allowed to rip off patients? That's why I describe this one as provocative.
Yeah. That's a very specific question and speaks to a service. Perhaps I would just say that in the area of artificial limbs, there are concerns that what we are able to produce by the hospital and what is demanded and what is supplemented are all areas that we have to look closely at. Again, should the finances and the trained personnel who are willing to work here be unlimited, we could respond immediately to every concern. This is one area that has been noted and solutions being sought. Yes.
Yeah, I think, Dr. Cave, that monopoly situation, when one person provides service, always prevents difficulty, particularly from a financial management. And as we said, when I said earlier, we're tendering everything, we're going to market, I think you've been looking in Trinidad and Dr. Cave, I think, and other spaces to see if we can find a competitor to be able to get someone else who's able to produce the quality of service. So monopoly position always presents. I think we've answered. We don't mind provocative questions. If you set as your mission to be an exemplar of good corporate governance, then you have to be, as an institution, ready and able to answer any questions. So where we recognize there's an issue like the question on recovery of insurance, once we understand it, we are then in a position to tackle it. And a monopoly situation is always a difficult one to find. And I think this person had a monopoly for maybe over 10 years or so. There's not been a competitor in the local marketplace.
Thank you very much. Go ahead. You can, from there.
Yes.
This might come on in the ambit of the provocative ones.
Don't mind.
As a user of this institution over the years, and interacting with the public and so on, in the different presentations, especially from Dr. Cave, the use of the A&E and so on, a lot of emphasis is placed on the patient, user, client, whatever you want to call us at a particular point in time, for us to use the facility correctly and so on. But the public notion out there, and my observation and my feelings sometimes, and I can use what we say out there in the public, some of them doctors is young like lords. Nobody can tell them nothing. The hospital, they got the control over them. They could do with the light, come in with the light. Because sometimes you get an appointment and you go in the outside, I think the doctor turn up. So how does the hospital address these lords, so to speak?
Wait, that's the ultimate provocative question.
I would not want to deny that we do have individuals who practice in a way that others in the institution would not like to see. There are pressures from working in the hospital where there is a pressure for number of patients, the way in which you are supported in doing your job, the hours that you have to work. But these are problems for the doctor to address. It's not the problem of the patient. On the other hand, when you have patients who may also be lords, who demand their satisfaction before others, and you have to prioritize who gets seen first, it's not always going to be a popular decision. So the perception of, I've been here since 8 o'clock, I must be seeing when your appointment was at 10, means it's not about seeing you early. It's about displacing the person who should have been there. So in trying to provide all things to all people, which is why I captioned the slide like that, there are going to be some people who are disappointed. Not to say that there are not individuals whose communication skills are not as we would like them to be. For those ones, I do apologize, and there is a part of their training, both as undergraduates and postgraduates, that should address this. Okay, but it is not. Medical service is not equivalent to Antoine's service that he gets at Chicken Barn. It's not always going to be the customer is right and who comes first is what's going to happen at that moment. So it's a conversation between a patient and a physician rather than a customer and a commercial service provider. That's why medicine and hospitals are different. I don't know if that addresses some aspects of what you are asking, because it is, let's put it this way, from a doctor's perspective, it upsets me leaving the hospital after visiting hours to see the way visitors have treated the institution by the trash they have left behind and thrown out of the windows, and to hear the way they speak to some of the junior doctors and nurses, particularly. So it's a two-way street. Certainly.
In addition to that, what Dr. Cave is saying, my observation also of outpatient dynamics is that you can't be two places at once. So there are many times, although these clinics are fixed days, that the consultants would have been post on call. So today being Thursday, I was on call yesterday, and I now have to go through all of the patients that we would have admitted on my service in the morning time, conflicting with clinic. So usually they're not physically at clinic because they're also doing the admission, going through the admissions with their team, and it's from A&E to the A floor because they're the overcrowded situation. Or for the other services, if they have an emergency on the ward, the entire team may not be there, one or two persons to start the clinic, and then the other team are on the wards dealing with one or two cases before they come down to clinic. So yes, you may have the scenarios that Dave mentioned, but sometimes physically, they just can't be two places at once.
So is this a question of capacity?
It's a challenge because.
But could I also add something just to round it off? Because I want to add that it's also about change management, to answer your question about, who's Lord, and change management, because doctors, nurses, everyone leave Barbados and they go to hospitals, other parts of the world, and they behave differently. Why do they behave differently is because of the culture that's been built and the accountability measures that exist. I was given the example today that a relative of mine given of a nurse basically who was being taunted racially just in a hospital overseas. Finally, this nurse got so upset that she basically told the patient off. She just, she was a Trinidadian, in real terms, in Trini ways, told her where she could go. That nurse, I think the person that was telling me the story, when she finished the encounter with the patient, she just went and put on her jacket, and she says, well, I'll see you when I see you, because she knew that she would be terminated. So she made a decision, and when she reacted out of anger, that
she got it off her chest, but she knew she would not be working at that institution anymore. Nobody had to tell her that she wouldn't be working there. She literally, and this is a true story, went, and she was able to come back because the person told me that they reported it as a violence. That what was happening is that the patient was being racial to her, and she reacted badly. But the point I'm trying to make, not to take away from the point, is what we have to build in the hospital, which takes time and leadership at all levels, is a culture of accountability. If we build, this is what is lacking here across the length and breadth of the institution. So Dr. Cave is correct, and Shaney's correct. You can't be in both places at both times. But somebody has to communicate to the patients that are waiting, hey, Dr. So-and-so is due for you at 10 o'clock, but unfortunately, there's an emergency in A2, and he said if you could hold on, he will come. That kind of customer service engagement, or if people are not showing up when they're supposed to be showing up because there's a conflict, that they're held accountable. And I'm saying that is something that has to be built across the institution. The leadership has to, because what happens is there are excellent physicians who are here. They're making their appointments on time. They're doing what they need to do. But the few outliers are basically what are coloring the perception of the entire group and category of staff. And I've said that is why we think that the collective needs to hold each other accountable, and as an institution we have to do more to build that culture of accountability.
Thank you very much. And you've received an applause from Joy.
Yeah,
Comment.
thank you. Joy Workman, it's good to see you.
Now everybody know who you are.
Yeah, she's excellent. She's excellent.
Thank you very much. That brings an end to the public accountability meeting. Certainly, we would want to thank all those who are involved. I recognize Executive Chair Juliet Bynum Sutherland, Dr. Clyde Cave, Medical Director, Medical Services Acting, as well as Adrian Hurley, Director, Financial Services. You who are here as members of the audience, in whatever capacity, we thank you for being here. We thank you for your line of questions and your interest. And certainly that can only redound to betterment. To the entire team, those working behind the scenes, communications and technical, we also offer our thanks to you, because without technical, as I say all the time, coming from another space, we can do nothing. So thank you so much. Of course, you would want me to also thank our Facebook audience. May I remind you, if you have any additional questions, you can post them at feedback@qeh.gov.bb. And I know that there are always questions, and there will always be answers. And I close with a comment from Rosemary Allen. This was also posted on Facebook, and perhaps this is something that we can look at. She said this is something that should be carried by the national broadcaster, CBC. Perhaps that starts a conversation.
Yes, thank you. Thank you very, very much.
So ladies and gentlemen, thank you once again, and it was certainly my pleasure to act as host and moderator for this public accountability meeting. Thank you so much. Travel home safely, those of you who are going. Those of you who have to stay because of work, well,
Thank
part
you.
of the course. Thank you so much.
Thank you, everybody. Thank you. Yes, thank you.
Big side.